meeting to the public, and public are very encouraged to ask questions, which we'll deal with at the end, and I'll go to Michelle to see if there are any. And as part of the recording process, live streaming process, this will also be recorded. So hope everybody's happy with that. Now, as you will be able to see, some of us, shall we say, especially if you were listening to the chat as we were waiting to start, some of us are wearing our Christmas jumpers, and thank you to everybody who has remembered to do that. So it is Christmas jumper day, but for a very good reason, and Michelle will put a link in the chat to a charity, but I'm just going to ask Susanna to say a few words about the charitable support that we're looking for today. So over to you, Susanna.
Okay, so hi everyone, and thank you to everyone for wearing their festive attire. I've heard that from some colleagues that extends to their socks as well, but I asked them not to share those on camera. So yes, Christmas Jumper Day, we always meet as a system on the second Friday of the month, and so that often coincides with Christmas Jumper Day in December. So for quite some time, we've worn Christmas jumpers, and usually had a local charity in Suffolk and North East Essex we've supported. This year I've suggested a charity which I happen to know well myself in North East Essex. It's a charity called Nest. Nest do excellent work in the community right across North East Essex, in Clacton, in Harwich, and in Colchester, supporting some of really our very most disadvantaged families. And each year at Christmas, they compile a list of around between kind of 120, a couple of hundred families in North East Essex who simply are unable to afford the very basics that most of us take for granted at Christmas. So food, gifts for children, and also a little bit of money to make sure they can run their heating and so on over the Christmas period. Those hampers are distributed by volunteers. It's something I've done. It's an incredibly humbling experience to reach out and go to visit a family a day or two before Christmas to hand over food and, as I said, Christmas gifts and so on. And when I've been out to visit those families, often they literally have nothing, sometimes not even basic furniture, because they've needed to be rehoused at short notice and so on. So Nest, I did send around an email with details of their website. We're going to pop the donations link into the chat. And I know that some colleagues, I think Andrew, Kelso and colleagues are planning to volunteer this Christmas with Nest, going out to visit some of those families. But about £120 would actually enable them to give another hamper to a family in North East Essex. So I do think it's a good cause, and I have to say it's one where you can see a really direct impact of a donation that you make, and one that's very local to us in SNE as well. So thank you, Will.
No, thank you, Susanna. And Kathy, thank you for putting the link into the chat. Kathy, would you also take an action to pop that link out by email for those who either aren't here today or can't access the chat, so that link is available to all? That would be really helpful. Okay, thanks very much, everybody. I'm going to go straight to Michelle for apologies. Over to you, Michelle.
Thank you, Will. Nick Hume sent his apologies, and deputising for Nick is Shane Gordon. And Tracy Rudland has also sent her apologies, and Tristan Easy is deputising for Tracy.
Okay, that's great. Thank you very much. So then let me deal with declarations of interest now. These are declarations of interest or potential conflict of interest with any agenda item, but you don't have to declare those interests of which we're aware already. So let me see if any hands come up. I don't see any yet. Could I just, unless any come up, we'll take that as no declarations of interest, but could I also ask you to, in a quiet moment, all have a look at the workbook which you've got in the papers pack, there's a tab in there on declarations of interest. If you could just make sure that is up to date. And I think as well, Susanna, you and team will be taking an action to do a prompt out for those who aren't here today. You'll do a prompt to all for an update of that tab. Yeah, I hope if it could be done by the new year, that would be really helpful.
Yes, so we're going to write out to members of the ICP with a request around declarations of interest and also just a rough guide, because the breadth of the ICP is quite considerable, but it is an opportunity for members to declare any interests that they think are relevant to the work of the ICP. Thank you.
Okay, wonderful, thank you. And I still see no hands raised for declarations of interest, so we'll take it that there are none. And in which case, moving on to the minutes of the last formal meeting, the 14th of October 2022, I wonder if we could take those first of all for accuracy, please. I'm going to try and take them on block, so I won't turn the pages. Any comments or points of accuracy that anybody wants to raise? And again, I see no hands raised, so we'll take it that the ICP today agreed the draft minutes of the 14th of October as a true and accurate record. Lovely, thank you. Just to note that, of course, we've had a meeting since the 14th of October. We had a meeting on Remembrance Day for those of you who were there. I found it a very powerful meeting, actually, in very many ways. And thank you to all who put so much effort into that. But it was a strategy meeting, and there are no minutes of that as yet, because the feedback was into the strategy process, which you'll hear more about later. But could I just ask you to check the attendance log again in the workbook, please, because we didn't, there were so many people and it was such a big event, as you know, we didn't go around formally checking attendance. So just in case we've missed anybody, make sure if you were there that the workbook shows that you're there. And perhaps you should also, while you're doing November, have a look at October as well. Make sure we've got it right. You know, this is a big meeting, potentially with over 60 people at times. So it would be easy for us to miss somebody, I'm sure. So let's make sure we've got that right. And then we'll look next year, we'll start looking more formally at attendance and attendance records and so on. And that then takes me on to the workbook in the action log itself. You've received the workbook. I'm going to hope that perhaps we can receive it again as an accurate and complete record, subject to you checking your own attendances. Has anybody got anything they would like to raise from the workbook itself? Otherwise, I'm going to take it as received and noted. And again, I see no hands raised, so thank you for that. And thanks for this, a very useful workbook, team. So thank you very much for all the information in there. In which case, then, moving rapidly on, and we're going to go at quite a pace today. I suspect it's a big agenda. And also, you will have noticed that the last two items are for approval. And there's a reason why I won't go into it. There's a reason why they're the last two items. But what we mustn't do is impact for approval, not debate. We mustn't impact the time available for those items. So I'm going to do my absolute best to keep us to time. So moving on to item 3, equality, diversity and inclusion, and our ambition. Susanna, all yours.
Okay, so I'll do the two together. So colleagues will remember at the meeting in October, which was an online virtual meeting, we had two focused discussions on two really important issues for us in the integrated care systems. The first was around equality, diversity and inclusion in our health and care workforce. And the second was around specifically, again, around our response as a health and care system to the cost of living crisis. What we've done is to summarise the notes of those discussions. in a way that reflects, if you like, the way that as a ICP we'll begin to describe our kind of collective vision and collective kind of strategy. So they're focused in kind of, each of them draws out kind of a handful of key themes. So I think both of them have 4 key themes. And the way that they're stated is kind of a kind of collective ambition about what we can do. What's really important is that we now take these forward in terms of action. And of course, that's the role. It's in particular our 3 place-based alliances that are engine rooms and system for delivery, but obviously individual organisations as well. What would be good is some endorsement this morning from colleagues in the ICP of that summary of our kind of collective vision and thoughts on those 2 important issues, so that then on behalf of the ICP we can then forward those on across the system to where kind of the work gets done, if you like, to ensure that we kind of carry those that great vision into kind of some reality across the system. So I won't go through the 2 papers in detail because we're there and we spent time on the discussion, but I'd be grateful for support to take that to the next step this morning.
Wonderful. Thank you, Susanna. And obviously colleagues have already debated these issues, so hopefully you'll feel the summaries are accurate. I see Nikki's hands raised. I'll come to you in a second, Nikki. Those just to feedback for colleagues on these papers were debated at the chairs group meeting on, I think it was Wednesday this week, and correct me if I'm wrong, Susanna, but I think the short version of that is there was great and passionate support for the chairs for these papers and indeed the action you've proposed. So Nikki, over to you.
Thank you very much, Will. Good morning, everybody. I'm Nikki O'Shaughnessy, Director of Local Delivery for North Essex Children and Family Service, which is Essex County Council. Yes, I am happy to endorse the papers. There is one area that I just wanted to raise, please. We refer to our patients, and actually we don't have patients. It's about the language, really, that I wanted to raise, and how we have consistency of language and approach. I think it's really important. It sounds very clinical. It sounds very cold. I know Ed's on the call. Ed's heard me raise this before, but could we think about that? When we met with Lisa Nobes to do the quality strategy, we came up with our people. And in our people, we put a descriptor, which you'll see in the paper, around what that actually meant. It's a warmer tone, it's more personalised, and I think it moves us away from patients and the clinical aspects of that. So I would hope that people could support that approach, please. Thank you.
Thank you, Nikki, and good point. And also, good point that you made on a sort of emotional intelligence point of view. Absolutely get that, and I saw lots of people nodding, by the way, around the screen while you were talking. But also, it's a good system point that you're making, isn't it? So the collective. So should we take that as agreed, unless anybody disagrees? Should we take an action to, what's the right phrase, Nikki, to systematise the language appropriately in the papers?
Yeah, it's all about relationships, and it's all about how we embrace relationships with real people. So we would want to do that from a strengths-based approach.
Yeah,
thank you.
Good point, Nikki. Thank you. And then Andrew.
I think this is a really great step. Thank you, Susanna, for bringing it, for doing the work preparing it. In the spirit of trying to make it even better than it is there an opportunity as we iteratively do this to actually make some of the statements more active? I reading this, I feel a lot of them are quite passive. They're all about making us receptive to diversity, but actually we could go one step further and say we're actually going to seek out and encourage diversity and promote diversity. And I appreciate some of that semantics, and the spirit of that was probably meant to be in this as well. But I do feel we could perhaps, as we develop this work, take it a step forward.
Let me see Susanna's nodding, but let me go to you, Susanna, for the mechanism for doing that. The reason while you think about your response to Andrew, I'm not disagreeing, by the way, Andrew. I'm just thinking how we approve today, subject to some mods. There might be an electronic circulation coming up. And actually, Susanna, just before I bring you in, let me go to John.
Yeah, well, it's a very good point. And there is one thing about what the policy says. There's another thing about the actions we agreed to underpin it, Will. So it happens that last night I was with the LGBTQIA plus group in Essex County Council Social Care. One of a series of 7 quests we're doing. We started with race, we've done disability. And it's actually fascinating when you create this mechanism to listen to their lived experience. And I would say to you that we one thing, let's agree the policy, but let's also think about how we might do exercises of this nature to find out really what the true state of the world is, as opposed to the state of the world we'd like to think it is. I certainly got some pretty clear guidance last night, as I had previously at the last 2 sessions.
That's a good point, John. Yeah, thank you for raising that. And Susanna, I'll just hold you at the moment and pick up Andy, if I may, as well. So, Andy?
Just very quickly, do we have a strategic equality and quality impact assessment in place? It's a kind of toolkit that you can bring about that looks really internally and externally, outwardly, for any system or an individual organisation. It's something that we adopted earlier this year.
That's a good question. Let me then go to Susanna to try and mop those up. Susanna, hold yours.
So it sounds to me as if colleagues are suggesting some action, really. So there's a couple of things. I mean, the first is, Andrew, yes, please, your help in making those statements more active would be appreciated. And so if you're offering to help to do that, I'd be grateful. But still, I think we need to make the point of them pushing something on. And Andy, again, that sounds like an action really about something we need to think about. So this conversation was specifically about equality, diversity and inclusion in the workforce, our health and care workforce. And then I think you're raising a wider point really about how we work as an ICP going forward. We have done the work over the last year. We've completed equality and health and equality impact assessments of a number of key programmes across the system. And one of the things that came out of that was a sort of high level generic kind of statement. We're using some of that in the strategy, but perhaps if we could have an offline conversation about what that would look like, I think it's an excellent idea and something maybe we could then do some thinking about and come back to keep this conversation live with the ICP.
Okay, so shall I have a go at summarising what I think we're agreeing as an ICP committee here today? That we're very supportive of this subject as drafted and as debated previously by the ICP. We're supportive of the paper and the papers, 2 papers, and the direct summarising our discussions. And we're supportive of the direction of travel and indeed the action proposed that once agreed that these papers go out to the alliances, if you like, for action on delivery. But we do see some drafting issues on specific wordings. We see an improvement that could be made in making these papers more action orientated, which we all buy into. There's the future issues of EIA and lived experiences raised by John and Andy as well. Susanna, would it therefore be appropriate to say that there'll be a further iteration with colleagues, as you suggested, and I know you'll appreciate help from all, there'll be a further iteration of these papers and that we'll perhaps circulate a next draft electronically? I'm just conscious of the length of time if we receive them at the next meeting. What's your feeling on that?
So I think maybe if we treat them both slightly differently, I think certainly there was the conversation at the chairs group earlier this week reminded us of the urgency of taking action around the cost of living crisis, and the amendment that Nikki suggests is easily made. And I can make that, and indeed I've already shared that paper in its draft form, for example, with the Collaborative Communities Board in Suffolk and the Alliance colleagues there. So I'd like to get the cost of living one forwarded on and for action as soon as possible, if that's okay. And then, but obviously I'll copy ICP members into that distribution. For the equality and diversity paper, I think what we're teasing out is that that's a bigger issue and a longer term and an ongoing issue. So I think Andrew's suggesting going a little bit deeper in terms of kind of how we state that, and Andy's suggesting then really work to be done by the ICP and in the new year. And so on. So I think if it's okay, I'd like to separate the two, get the cost of living one out, but then come back to the issue about equality and diversity in the workforce to the ICP.
Great summary, thank you. So cost of living appropriately wording drafted and wordsmithed as necessary, then issued. Everybody content with that? And further work on the EDI paper as discussed. And let me just bring in Ruth. Ruth?
Yeah, I was just going to say, I think the EDI piece is really important to me, and it's something we're working on internally in the Fed with some progress. So if you want some support with discussing that, I'd be more than happy to join. Andrew.
That's great. Thank you, Ruth. So you've got at least 2 volunteers there, Susanna, if not more. And I'm sure Susanna would, if you drop her a note, she'll appreciate your support. I think also, do correct me if I'm wrong, although we're saying more work needed on the EDI and we need to go into it in more depth and so on, we're not saying do it slowly and it's not important. It still is important and needs to progress as quickly as possible. I think, again, I see colleagues nodding to that. So let's make sure the minutes capture that sentiment. We're not downgrading it. What we're saying is actually it's so important. We're going to do a bit more on it, but it's still urgent and we need to progress as quickly as we can. Okay.
Will?
Yes.
There's a question from Shane in the chat.
Oh, thank you, Andy. I'd not spotted that. Shane, do you want to come in and ask you a question?
Well, I think it's on that theme of kind of deepening and making more precise our plan of action around equality, diversity and inclusion, because the paper's it's full of good aspirations, but there's not a lot in there to get hold of that's very specific around what we're actually going to do to move the agenda on, and nothing at all about how we're going to know if we're succeeding. And I think particularly after the experience of the pandemic, that feels like a bit of a weak response to the challenges of ED&I. It doesn't feel like, I know we're going to go back and revise it, but the paper doesn't feel like we're taking it seriously.
And Shane, I'm sensing an offer to help from you there.
Absolutely. I'm not sure we're experts at it, but we're having a good go at trying to do some of these things.
No, that's really good. Good point. Thank you. Well made, and your offer of assistance gratefully received. Also, I noticed Amanda, you're offering to link up with the ICB work, which is great. Thank you. We'll take that as done. And Peter Fairley, did you have would you like to make your comment?
Yeah, Bill's on the point that Councillor Spence made, but the quests that we've been doing in ECC, I know that I think we've established some links with you, so certainly happy to kind of share anything on that. There's potential to take that kind of quest approach as well from where it is at the moment in ECC, which is with some of our staff, out into the communities to see what it's like for for our people as well. So if there's any learnings, we're very happy to share it, and we can pick up offline.
Can we volunteer Elaine Oxley, Peter?
Elaine Oxley, definitely.
We'll volunteer her. Okay.
That's great. Thank you both. And Lucy, you've also got a lived experience point there. Would you like to make that as well? That'd be really helpful.
So I was just saying that it's the same quest work. It is that kind of lived experience. And as Peter says, we've talked about not just applying this internally to our staff, but also to our service users. As I said, I genuinely, there is nothing like people who will share the good and the bad, because it's not all bad. Let's be honest, we are doing some things well and we're doing some things right. And we must remember that as well. But it's completely different understanding the context and the kind of frequency, etc., and sort of the passiveness sometimes. There's a passive aggressive and micro, what are they called? Microaggressions, Peter, is that it's really quite extraordinary. And also it's quite not guilt-inducing, but it does make you really reflect on how you may have some real unconscious biases in the way that the training, which I do rate actually around unconscious bias, but it does it in a way that the training just cannot.
Okay, excellent. Thank you. Thanks, Lucy. Okay, thank you all. That's really useful. And I think, Susanna, you will have taken that very supportive sentiments away for the further work on the EDI. So with that, colleagues, I'm going to take the next item. Happy to move on, in which case ICB report back. Ed, over to you.
Thank you. So I think this is just to very briefly highlight some of the discussions at the last two ICB boards. I know, Will, you gave an update at the last one of these meetings around the 27th of September. The highlight in that meeting was the presentation on the training academy for the Clacton Community Diagnostic Centre, which is an amazing collaboration between Colchester Institute, the NHS, and supported by Essex County Council. I think, Shane, there's almost 70 people now that have gained employment on the back of the academy, which is phenomenal. The majority of those people are local to Clacton, and at least half of them were previously unemployed. So it's a really incredible achievement. On the back of that, we've gained resources from Health Education England to spread the approach within our system, so spreading from Essex into Suffolk, and we're very excited about doing that. So that's been a great achievement. On the 22nd of November, you haven't got the minutes of the meeting yet ready, but the three kind of highlight areas is we had a superb report from Health Watch around elective weights and highlighting the areas where we need to do much better to support people on those waiting lists. Secondly, an excellent presentation from our primary care training hub, who really come to the fore in recent times, and certainly I've been working closely with them in a couple of practices, and I've really been very impressed. So that was great to hear from them. And then finally, we heard from both county councils around care tech and some of the exceptional work happening around care tech. And I think I'll be confident in saying that we're not to that level yet in the local NHS. So we're going to look about how we can integrate approaches with the councils, and certainly I know in West Suffolk Alliance they're making some very good progress there in terms of integration with Cassius Plus. So those will be the updates, Will, if that's okay.
That's great, Ed. Thank you very much. So, colleagues, any questions or further updates on that report back? Otherwise, we'll move on. We'll say received and noted. Ed, thank you very, very much. Move on to item 5, please. The update on strategy development. Susanna, all yours.
Okay, so this is just a bit of an update, but also I'm going to start to show you now how some of our strategy is beginning to look. And I know colleagues are very keen to see this now in the flesh, which I think will start to be the case from today and over the next couple of weeks. So going very, very briefly, colleagues remember that we have guidance on developing integrated care strategies across all 42 integrated care systems, and they're really important because it's for the first time bring together a kind of joint strategy for the whole system that will be very important, in particular to NHS and local authority partners. We agreed very early on some principles for how we would go about the development of the strategy, which I won't go through because they've been in my previous updates, but just to make a couple of points, which is that we were very clear as a system that we would build on work that we've done previously, we would use an outcome-based approach and a methodology to underpin the strategy, and that we would engage and involve stakeholders in the development of the strategy. So the way that we've approached our integrated care strategy development is summed up. I know I use this cartoon a lot, but it still stands, it always stands, which is that we really are trying to shift our focus all the time away from thinking about strategy as being about individual organisations, and really trying to shape it around people. And Nikki's point earlier on was well made. So we've been asking two key questions at the heart of our strategy. The first is what matters to you and why? And the second is, how should we be thinking differently in health and care? So we've just literally this week finished what's been a quite considerable period around engagement around our strategy. So a huge thanks to colleagues from both Healthwatch Essex and Healthwatch Suffolk, who've been absolutely superb through this process. Their wider teams have really gone above and beyond to make sure that they've brought people with lived experience into every part of the conversations that we've been having, as well as supporting some direct engagement. We've held a number of kind of community conversations with voluntary community sector colleagues and in libraries and a number of other places. Our pop-up video booth has been out to 16 different locations around the system, and we've got in excess of 500 members of the public on who have filmed comments around engagement. We've in that tried in particular to engage with health and care staff, in particular staff from social care, who we felt we hadn't really heard enough from previously. And then last but not least, we've held 15 theme-specific kind of co-production workshops where we've brought together people with lived experience, clinicians, professionals, those who are sort of strategic leads in health and care, if you like, around perspectives of particular groups in our population. So enormous amount of work, and the last of those workshops was on Tuesday. So I'm not going to go into detail, but that's kind of what those workshops kind of covered. The other thing that we've been mindful of is that as we've been going through this development, also we've started to see something of how the CQC is looking at reviewing integrated care systems starting from next year. And this is just one slide out of a pack that caught my eye, because this is a description from the CQC of what kind of working together means for people, which is very much the language we'd hope to have in our strategy. So these statements here, are I statements, and we're using I statements in our strategy. But it strikes me that kind of what they're describing really is what we've been meaning by can do health and care in Suffolk and North East Essex for some time. So there's a number of things that have informed, if you like, some of the thinking and language here. So just to give you a kind of quick, first of all, just an overview of the kind of key areas that we're covering in what's a very detailed piece of work, is at a high level, we've got kind of very high level summary of our strategy, which is basically just sort of we've sort of summarised this around sort of 6 numbers. So at a very high level, obviously this is a population strategy. So we're thinking about the fact that we're one team that wants to make the best possible health outcomes a reality for every one of our 1 million people we serve. Very mindful in our strategy of the fact that we work with partners more broadly across both Suffolk and Essex more widely. So we've been joining up with colleagues in particular across, for example, the 3 Essex ICSs to make sure that we're aligned. Very mindful as well about the principles around local delivery and the importance of our 3 pace-based alliances. And then what I'm going to show you in a minute is our 4 kind of ambitions. And we've got 4 ambitions in strategy. And then the principles around equal parity between the kind of 5 different sort of sectors that come together in our integrated care system, and the 6 values that we worked on around transition that underpin our system as well. So in terms of those 4 ambitions, to take you through those, the first is the ambition around the best health and wellbeing for all. So What matters, what people have told us, what matters is that those health and wellbeing outcomes can be a genuine reality. And of course, we know that the things that kind of drive our health wellbeing outcomes are not so much about services. They're to do with how we live, where we live, and so on. So we've had that conversation around resilience through a sense of belonging, safety and purpose. Just a week ago, this time last week, we were having a really good workshop, Thinking Differently Together event on those themes. It's about healthy neighbourhoods, healthy lives, good homes, good work and education, good environment, good communities, healthy behaviours and avoiding harm and being protected from avoidable diseases. On the right-hand side there, you'll see, our ambition is to make that a reality, and how we will begin to do that, which is about supporting people to be resilient, working upstream around the wider determinants of health, focusing on the things that drive the gap in local life expectancy, looking at the areas where we can make the most difference, minimising risk factors, removing barriers to health that are experienced by people who experience inequalities, and also taking action at every opportunity around prevention as well. So that's the draft of our first ambition. A second ambition is around health equality, and this is about having the same opportunity of good health and wellbeing, regardless of ethnicity, race or religion, gender, or if you identify as LGBTQ+, or if you live with a physical, sensory or learning disability, if your circumstances mean that you are experiencing deprivation, homelessness, or growing up in care, or living in a coastal, rural or traveller community. And our ambition for that would be framed around focusing on overcoming, again, barriers to health equality that exist through enabling health equity and social justice, being allies to people experiencing marginalisation and disadvantage, speaking out against discrimination and injustice, being aware of our own individual unconscious bias and also the structural and institutional discrimination that exists, no doubt exists in wider health and care systems, assessing equality and health inequality impact of what we do, both as individual organisations and collectively as a system, and everyone being accountable. The third ambition around Live Well, this is where we've adopted the Live Well domains now across our system. So this is about being able to continue to live well. It means being able to start well right from before conception through pregnancy, birth, childhood and adolescence, being able to be well. We had an excellent workshop talking about the importance of oral health and dental health, good eye and ear health, and good health for your depending on your gender. Being able to stay well, living with cancer, long-term conditions, if you're living with obesity, living with if you require urgent emergency care, or living with a disability. Being able to feel well if you have a mental health problem, addiction, or a survivor of trauma or abuse. Age well as you grow older, particularly with frailty and dementia, or die well for yourself and also those that are close to you at the end of life. And we're really clear that to do that, we need to not just think differently, we need to do things differently. And that's where, the real power of the ICS in terms of its delivery through neighbourhoods, alliances, working with partners across both counties, across the system and more widely, so important. And the other thing is that the importance of co-producing with people and families, really collaborative programmes. And then last but not least, I have to say, having listened into the content of the feedback that we've had from our engagement, very often the way I would sum up what people are trying to tell us is that what they do want is they want us to be more genuinely can do as a whole health and care system, and they want to be able to trust the health and care system. And that means being listened to and heard, being treated with kindness, dignity, respect and compassion, being able to access diagnosis and support in a timely fashion, and then having care and support that enables us to live, to see as a unique person what happens when you move between services, and that care and support is coordinated and everyone works well together. And this is where, of course, we've got so many programmes and so much strategy in our system, which I've kind of organised in this around those core values. So they are about being collaborative leaders, being collaborative, if you like, in terms of thinking about our whole health and care workforce, every part of it, and being collaborative around our data, linking data and analytics, compassionate, personalised care, family carers, and genuine co-production, courageous, enabling that equity, inclusion, social justice, again, comes in there, clinical care quality, and the role of clinical care professionals, community focused, resilient. We're clear, aren't we, about a resilient voluntary community social enterprise sector, the importance of volunteering, the role of community connectors, anchor institutions and community pharmacy, and then creative, the use of digital data and technology, innovation, research and environmental sustainability, and cost effective. It's about financial sustainability and our other resources as well around the estate. So that is our high level overview of the strategy. Now, the other thing, when we went back to how we said we'd set this out, though, is we said, look, we're going to use measurement. We want to use an outcome-based approach for our strategy. So this is a quick whip through what that looks like. What an outcome-based approach to strategy means is identifying clear outcomes, and outcomes are high-level statements. People living with cancer in Suffolk and North East Essex stay well. That's an outcome. And then understanding the indicators that we have of whether or not we're achieving the outcome. What are the indicators that we're considering? Now, we've got excellent resources in both Essex and Suffolk in terms of the work that's been done around the Joint Strategic Needs Assessment. So we've drawn heavily on that. But also, more importantly, we need to dig deeper and understand the story behind those indicators and therefore that outcome. So on this example of cancer, these are some of the things that at the workshop we looked at. We looked at lived experience, barriers to screening, impact on people's lives. We looked at evidence from many different organisations around outcomes and inequalities, and so on. And out of that, we then start to build, what are the benefits for the population? This links to that question about what matters to you and why. The benefit is what's really important that we get right. What difference do we need to make in people's lives? Because based on the story, we believe that will move the outcome. And then we can think about how we can think differently to enable those benefits. That is the scope for our strategy. And then just to put that in context, it will then be over to colleagues who are now working hard on delivery on forward plans to put together genuinely collaborative delivery plans, whether that's about how we work together, perhaps across the ICS or alliances or integrated neighbourhood teams that bring together contributions from the NHS, voluntary community sector and local government to deliver at different levels, wherever the work is done best, to enable those benefits that based on the story deliver the outcomes. That's our delivery planning. And Richard and I are working well at the moment around the joint forward plan to make sure that we get that dovetailing right. So just lastly, I'm just going to flip screens just to show colleagues then what then underpins that high level view of our strategy, which is that this is the kind of web-based version then of our strategy, which we will put live before the end of the calendar year on target. So I've dived straight into the example that I've just given you on screen about how that looks. So you'd be able to pick out under the Live Well domain, you'd be able to pick out people live with cancer. And you can see here that overall population outcome, and then the indicators that we've looked at here and some of the data which is drawn out of the data that we've looked at. We've then got the story behind the outcome. We've got some content going up here, which we've got certainly got some films, we've got some reports, and we've got some testimonials that people have shared with us, which are that's just Latin text at the moment because they're going in all the time at the moment. My team working really hard to pull this to get everything out onto the site. You can see here we've made space for published evidence that we've looked at in terms of developing that we've brought together. For example, here around evidence around race and ethnicity and cancer we've looked at, and the space for wider data. And we've also given all of the references as well. And then last but not least, the strategy sets out in brief that ambition, what matters and why, which are those benefits that we want to deliver. Those are slightly different to the outcomes. The overall outcome is we want people to live well. The benefit, though, and equally a conversation I think I'd like to have with some colleagues who are really good on measurement is about introducing different levels of measurement, not just measuring outcomes, but measuring benefits maybe as well. And then how will things be different in Suffolk and North East Essex? So these we statements, what we will do. Last but not least is we've also made room for some case studies. So you can see these showing up. We've added a couple into here so far. So for example, the Clacton Community Diagnostic Centre, what I'm looking for are case studies that are already written up. So we're adding those in here that you can link to. And at the bottom, we've started to map on all of the different documents and plans and so on that exist around our system. So that's just a very quick tour around the detail of our strategy. So as you can see, the work is both a kind of high level summary, but then if you like, quite some detail in terms of what is shared. And just to give you some idea, and just a huge credit to my team for their work and resilience really to try and do this the right way, which is that's the site map for the new website, which we'll flick on as soon as possible. So all of those are individual pages, but they're done on a template and most of the content is already kind of formed. So that will be the new site, which will go live at the end of the year. And just to make the point again, this isn't then the end. This hopefully, I think, will give us a tool to work more together around strategy going forward and to start to really weave measurement and to share all of that different work together. So that's my update, Will.
Susanna, thank you very much. And also thank you for making that last point. Because I was going to ask you to say it if you didn't. So thank you for doing that. That strategy is never finished. Is for a process of continuous improvement and review. So thank you for the update as with respect to where we're up to today. But I think we do need to encourage our ICP colleagues today, do we not, to not consider this to be a finished job. In fact, it probably never will be a finished job. A couple of hands are raised. Could I also say, colleagues, there are some comments in the chat. Do be aware that the chat isn't accessible to everybody. So Peter Smythe, Peter Fairley, and Nikki and Andy, I will come to you, if I may, for you to make those points. But let me deal with the hands raised first. And I see one of them is Andy's anyway. But let me go to Nicola first. Nicola, over to you.
Thank you very much. Thank you, Susanna. I thought that was genuinely really impressive. To see it come together like that is fantastic. And I just wanted to make the point about, or expand the point about indicators and benefits, because just looking at the indicators that are listed there, I think there is always a risk that we return to measuring what we can measure, and actually staying well with cancer requires perhaps more sensitive indicators, and so I'm wondering how it links to commissioning new research or commissioning sort of evaluation of services and people's experiences in order to generate a range of measures that really respond to that ambition.
Nick, can I come back on that?
Yes.
Nick, you make such a good point that goes to the heart of this. I mean, Andy's just put a reminder in that we're still going through the lived experience information, but we talked about co-producing and really identifying with people what matters and so on. I think now we've got that and we've got that language in there. It's back to looking, okay, as you say, what are we measuring out of this at the moment and how could we do more? And that might be by bringing, if you like, some different people around the table, because the measures that are in things like the kind of more strategic things like the JSNAs and so on are quite limited. And that's where we might want to get into perhaps looking at some of our, we've been working so hard as a system on analytics support, BI, population health management, that kind of thing. We've got a fantastic team. Richard's been doing a great job of pulling together a great team in that area. So I think once we've got it in place, we can now start to go further, as you say, into those measures. That's what I was saying about, I think there's a conversation next year about measurable benefits, but the right thing to do first was to ask people what matters to them first, and then look to see if that's how we can measure that better.
Okay, thank you. Let me go to Andy next.
Thank you. I just wanted to say yesterday I was at a first, because it all happened again, co-hosted national meeting between NHS England and Improvement and Healthwatch England for ICS and for Healthwatch, local Healthwatch participants. And we heard a number of things, including the development of ICS strategies and forward plans. Suffolk North East Essex is the most inclusive by far. And I just need us to recognise that it's something that, as Susanna says, is there for us to work with throughout. This is a starting point, but it's actually a really, really sound way to have had it pulled together. And my piece in the chat was just to say that we're still receiving information from the public about it. Thank you.
Okay, thank you for that, Andy. And again, I saw nods around the screen, so thank you for making those points. What I'm going to do next is I'm going to go to Peter Smythe. Peter's got a question about primary care, and then I'm going to go to Sharon with a question about carers. So Peter first.
Yeah, thanks, Will. It was just to make the point that I'm not sure the general public will understand the distinction between primary care and the NHS made in the second slide, so that probably just needs a bit of thought. The other thing I would say, well, is the strategy seems very sensible, and actually from primary care there's stuff in there that we've been talking about for a while that looks great, particularly around cancer access and removing the gatekeeper bits. Really sensible. I think the challenge for the system and everybody on the call as leaders is to think about the implementation when our staff are so stretched that they can't see beyond the next patient. So to implement change in that kind of culture and then that kind of environment and embody the culture that this strategy talks about is the real challenge. And I think that's something that's worth just reflecting on.
Great, thank you. I'm going to take that as rhetorical, Susanna, unless you want to respond. I think
I was just going to say that one of the areas, there's a couple of areas, if I won't go into it now, but where I don't feel we've got a focus on terms of collective work and the culture bit. And actually, we're going to talk about that in a little bit about leadership and so on. This has flushed out some areas where maybe we haven't got a focus on as a system. And I think you're right, Peter, that we need to lean in more into that, because those are the areas that come through around the engagement.
Marvellous. Thank you, Susanna. And then Sharon, could I ask you to make your point, please?
Thank you, Will. Susanna's already answered it, but I really just wanted to flag up the impact on carers and whether their views have been captured in the community conversations, because I think that would be quite valuable pieces of insight that needs to be included in the strategy. And I just want to agree with Andy. When I speak to my colleagues in other parts of Essex, we're definitely ahead of the game here in Suffolk and North East Essex.
Thank you. Okay, in which case then let me go to Peter Fairley this time. Over to you, Peter.
Yeah, thank you. And yeah, really useful summary, Susanna. It has been an inclusive process, and to be honest, to some extent, actually, that's been a challenge for the county council to engage, because there's been so many things that we've been invited to. But that's not a criticism; it's just a statement of where we are. Clearly, we need to start thinking about the implementation, because that's the crux of it, and we need to obviously ensure that there continues to be linked, which I know you have with the other ICSs, because we do need to be able to have kind of a golden thread consistency for Essex. I've just shared as well something that came out yesterday from Social Care Futures. I'll send it around via email, but it was in response to a House of Lords committee. And I think a lot of what they're saying there actually chimes with some of the aspirations around kind of well-being. So we want to live in a place we call home, with people and things we love, in communities where we look out for one another, doing what matters to us. And I think that links really well to actually what we're trying to talk about and the wider determinants of health. So I'll circulate that after the meeting.
That's great, thank you. And was there a point in the chat? I'm just conscious, colleagues, that the chat isn't accessible to everybody. Nikki, did you have a point in the chat that you wanted to raise?
Yeah, thank you, Will. My point was really about intersectionality, which probably also links with the equality, diversity, inclusion paper that we talked about earlier, but that people are more likely to be further disadvantaged by the interconnectedness of issues such as disability, religion, colour, gender, and sexuality. And we just need to be mindful of that in terms of how that further increases discrimination and disadvantage for people. And it's something that we're probably not as mindful as we need to be, because people are talking about it, but we're probably not talking about it as much as we need to. There's some really good training materials and TED Talks around it as well, if people are interested. But just wanted to raise that, if that's okay. Thank you.
That's great. Thank you. Point noted, Nikki. Thank you. So, colleagues, one more comment, if I may. I'm going to bring Shane in to make your point, and then we'll close and move on. So, Shane, over to you.
Thank you. I think the strategy is coming on brilliantly, and really encouraging to hear Andy's feedback around comparing that with the development of other ICS strategies. It's a real testament to the way our ICS works. I was just in the chat saying that I think the wider determinants of health are really well articulated in that. I think the access to and outcomes of treatment are still very important to people, and they are in there, but they're in there in a sort of in between the lines kind of way at the moment. And I wonder, particularly on the first ambition slide, there isn't any mention of treatment or diagnosis in there, and it's talking about health and well-being. And I accept all the wider determinants arguments that they're really important, but if you get sick, you need diagnosis and treatment, and that's part of health and well-being as well.
Yeah, that's true. So, and Shane, I saw nods around the screen as you were speaking, but what you're emphasising again is the whole system, aren't you? That we don't accidentally miss out something because we just take it as read that it's there, but that we keep emphasising that whole system approach.
Yes, and I think that our population will, they know it pretty quickly if we're getting it wrong.
Yeah.
So it is important, but
yeah,
as are the other things.
Absolutely. Yes, absolutely. Thank you for making that point. Thank you. So, colleagues, that was a great update, Susanna. Thank you very much. Some very positive response and some additional contributions and offers of further contributions, which I know you'll gratefully accept. So I am going to conclude. I think that the board would gratefully receive the update, is wholly supportive of the process and the position as is at the moment, fully understands and accepts that this is a dynamic and continuous, probably never-ending process, and is very supportive of the position and status as we are today. Everybody happy with that? Wonderful. Thank you very much, Susanna and team, and for all your hard work. Right, for the next item, focus on menopause, I'm actually going to hand over to Amanda to chair this item. So, Amanda, all yours, and no pressure, but if we could end as close to 11:05 as possible, that would be really helpful. Thank you.
Noted. Thank you very much, Will, and good morning, everybody. So menopause affects all of us, doesn't it? Either directly or indirectly, one way or another. And this morning, I think we've got menopause through 3 different lenses, and I'm really pleased to be facilitating this little session. So in a moment, we're going to hear from Sharon and Brenda on some research carried out from Healthwatch, Suffolk and Essex on the experiences of menopause of women living in South Suffolk and North East Essex. And then we're going to hear from Ashley and Ruth from Suffolk GP Federation on an invitation. And then I'm going to conclude our session on talking about the health and wellbeing offer for all of our health and social care staff. So without further ado, could I invite Sharon and Brenda to share their research? And am I looking for you to share your screen as well, please?
So I would be grateful if you could share the screen, if you don't mind. I think you've got the express. I can't see Sharon anywhere.
I am going to stand in as a cheap imitation of Sharon Westfield de Cortez. So I'm Sam Glover, and I'm Chief Exec at Healthwatch Essex. Sharon's had an emergency, so I'm going to jump in.
Thank you, Sam.
As Amanda has said, we have been carrying out this work across Suffolk and North East Essex as part of the ongoing commitment that we have as a partnership between the 2 Healthwatch organisations to the work with Susanna and the ICS. We're bringing this today as one of the reports that we've done as part of that process, but one we had far and away the most engagement in. So many people wanted to share their story around this, not just menopausal, but perimenopausal as well. And unfortunately, there are some good, but some quite distressing incidents in here as well. So I'm going to go over some of the recommendations and findings that came from this piece of research, and then Brenda's going to share the actual quotes and direct lived experience from the interviews that we took part in. So if we move on to the next slide. So as this says, this covered both menopause and perimenopausal. The first finding won't be a big surprise to you, and that was that there was some dissatisfaction in primary care. People had difficulty accessing a GP, which isn't unique to menopause or perimenopausal people. But unfortunately, when they presented with these symptoms, there was a lack of empathy, a lack of knowledge, and a lack of confidence and understanding around the topic. And there seemed to be a bit of a reluctance to discuss women's issues. I'm not going to jump on my high horse again about women's issues like I did on Monday, but we'll just leave that hanging in the air. There was also a lot of time taken to access appointments, and even more of a delay when it came to onward referrals for people who felt they needed a bit more niche support. The recommendations we've drawn together from the findings across this theme are that there should be a review of the training that's provided across health and social care professionals, particularly within GP practices, both on menopause and perimenopause, with regular updates to this training. So it's not just a one-off tick box, but actually it's an ongoing training programme, and that there should be specialists within the practice. Someone that a woman can access or at any point during that journey. This has worked really well in champion schemes that we've looked at for other cohorts, and it could also transfer to this. So Brenda, if we move on to the next slide.
Thank you. You have to excuse me. I've got a very heavy cold, which is why I'm just reading the quotations. But just to say that it was easy to combine this for Essex and Suffolk, purely because our results were exactly the same. So whatever was said in Essex was repeated in Suffolk. So we were told that one person was told by the GP, "What did I expect? You're a woman. This is what you have to go through, so get on with it." Someone from Suffolk said, "The male GP initially told me to manage my stress and didn't offer HRT, which was not helpful at all. Others offered me antidepressants, which I refused." And someone said, "I had to see a private GP to get HRT after I took in a list of symptoms. 3 years later, not one GP at my surgery had any in-depth knowledge to alter my HRT dosage, and it was suggested I access a private gynecologist." So next slide, please.
So the second key theme that we identified was a lack of support and understanding actually in the workplace. And the impact of symptoms on employment were huge. It affected people's performance significantly, and this wasn't always particularly well dealt with. Many employers didn't show appropriate knowledge or support or offer any reasonable adjustments around this. And there was a significant number of participants who had left jobs or felt they had no choice to leave jobs as a direct result. And unfortunately, people not going for the promotion, not going for the new job because of the symptoms that they were experiencing. We recommend that there should be mandatory training for managers and ideally all staff within a workplace. And as I spoke about with the champions within GPs, champions within the workplace as well, so that there is somebody that you can talk to and achieve greater understanding of your own menopausal symptoms, but also how to support the others that you're working with. And implementation of workplace policies around menopause, including flexible working and reasonable adjustments. We're getting used to reasonable adjustments in lots of other elements of work, and this is just an extension of that. People experiencing menopausal symptoms don't suddenly forget all of their previous knowledge, training, expertise, They just need some support through this period of time, and they're still fantastic elements to our workforce. And in an environment where we are losing fantastic staff hand over fist, this is just a way we can really support and retain that talent. Next slide, please.
And where it existed, it worked very well, and women were very appreciative of it. And I think the NHS has some very good quality support for women going through this. However, in Essex, they said, I've been advised I shouldn't be at work. I'm not fit to work, can't be relied upon. I'm yo-yoing. I've upset my colleagues, and now I'm being managed for not managing my workload effectively. And someone in Suffolk said, I've lost my job. My marriage is severely suffering. I feel as though I'm losing my mind. I've been prescribed antipsychotic medication along with antidepressants. I've gained 3 stone in weight. The hot sweats are leaving me completely unable to leave the house. The additional pain I'm feeling in my joints is unbearable. I already have arthritis. I'm suicidal most of the time, and I only turned 40 2 weeks ago. Brilliant. So it just shows that it affects every part of the life, but your job, your work is extremely important. And it's not just women in their 40s, people under 40 go through this too. Next slide, please.
So this, I think we've just looked at this slide around understanding within the workplace. So ambiguity of symptoms. Unfortunately, lots of people were misdiagnosed, and lots of people were misdiagnosed with mental health conditions. It seemed that across primary care, people were quicker to diagnose and prescribe antidepressants than they were to look at HRT or look at a list of symptoms together as a collective and diagnose menopause or perimenopausal. And often women felt that they were misprescribed or prescribed inappropriate medication, especially around antidepressant, taking away some of the traditional ideas and stigmas about a 50-year-old woman. This affects an awful lot of people across an age range, across a range of demographics, and that additional professionals in healthcare settings who specialise in menopause and have the time to discuss these different options and different pathways. Lots of people across this research said that they found real benefit in complementary therapies and alternative medicine. And actually, this wasn't often discussed with their primary care professionals. Next slide, please.
And women said, I had never heard of perimenopause beforehand. I Googled, can I die from bleeding too much? And that led me to find out about perimenopause. Another said, educate the GPs. No one should have to experience the barrage of abuse that I did from a female GP. So it's not only male GPs, it's also female GPs. So many of us are dismissed or put on antidepressants, and it's help, advice, and hormones we need. Next slide, please.
So there seemed to be stigma, sort of quite widespread stigma. And this brings me back to the women's problems, which were just not openly discussed. Because of the lack of education around perimenopause and menopause, not preparing women sufficiently. And not just preparing women, but women live with other people, they work with other people, they engage with the world. So it doesn't need to be honed in to just a small cohort of people that require education and training around this. And when conversations happen, they generally only included women, and it should be a lot more inclusive than that, which leads on to the recommendation that menopause and perimenopause is included in potentially a national curriculum, so that actually people understand about this at a much younger age, and that steps are taken to break that stigma around women's problems and it being a taboo subject that should only be spoken about in clinical settings behind closed doors. And the work of people like Davina McCall has been fantastic about raising profile here, but there is still a long way to go. Next slide, please.
I must admit, I'm probably older than most people here, and I went through it some years ago, probably 25 years ago. There was absolutely nothing about it. And I went on to HRT, not because I knew about it from medication, I knew about it from friends. And I took it and I was fine. But I think 20 odd years later, there's still so little known about it and so little research done. So I think when someone says there's a huge lack of education on this subject, and we should be told it's coming, what to expect and how to deal with it. And another, get it from the GP. No one has menopause expertise. There's no central menopause clinic that I could be referred to. I needed someone to take bloods, which they did, but to have the expertise to interpret them, which they did not. I, 20 odd years ago, had to ask my GP and tell her about HRT rather than be offered it, which is so wrong. And I think some people are still suffering this. Next slide, please.
Okay, so this is my final sort of key findings that came out of this. So menopausal and perimenopausal symptoms can be quite long lasting. They include physical, mental and emotional challenges, and that there was a societal view, many of the people felt that this was the point where females were past their prime. And that continued to play into that lack of confidence, lack of self-esteem, and feeling like they were excluded from a wide range of opportunities. So the recommendation here is that there are more avenues to support for perimenopausal, menopausal and postmenopausal people, including support groups, specialist counselling and training and therapy opportunities, and that these should be offered in as many formats as possible to ensure inclusion and not eliminate those that are digitally excluded. Digital exclusion does not just affect one cohort of people. There are many people who just do not choose to communicate in that way, or widens inequality gaps when we limit the resource that we provide for that. So it's about looking at all the different options to support people through that process. Brenda.
Yeah. So women should be advised at the age of 40 to start to look out for a variety of symptoms and not be left questioning their sanity. However, it should start, I think, a lot earlier than 40, so people know what to expect, as an earlier comment made. And one person said that I wasn't going mad. I told my private menopause GP that she was my last stop before mental health services. She said she'd heard that a million times. Women don't know this to be true. And I think that is the end of the presentation. But I think it highlights exactly what is not happening for women in relation to the perimenopause and menopause. You can see that there's more information, and the full report from West and East Suffolk will be going online, and I'll send the link as soon as I have it.
Wonderful. Thank you very much indeed, Brenda and Sam. Lots of rich data information, and I know we have quite a lot of hands. I think we've got 5 hands showing. So may I commence with Ruth and then Peter, please?
Thank you very much. And I think I'd like to draw attention to the third to last slide, I think it was, with the recommendations. Can I just declare some interests? I am a woman. I'm about nearly 50. I am a GP, and I'm about to present some slides with Ashley about things we're trying to do to help some women who are coming through the menopause. I thoroughly agree with the third to last slide that there needs to be done more. However, I do have concerns that this is a very one-sided presentation. I didn't hear very much positive, and at the moment general practice is under extreme pressure, and we are daily attacked in the newspapers. And my concern is, if this is published as it is, sorry, I'm getting a little bit emotional, what with my age and my femaleness, that if this is published as it is, that actually it's extremely potentially damaging, that it might make people feel that they can't go to their GP because they won't get what they need. This is a much broader conversation, as you quite rightly said. Other things are also helpful in the perimenopause. When I look at I've just opened up the clinical knowledge summaries about menopause. There was training for GPs 2 weeks ago in the East on menopause with one of our local gynecologists. It is something that we do experience. There are also challenges. HRT is not available. The prescriptions we want to prescribe are not necessarily available. I will challenge you that people are given antidepressants. Selective serotonin reuptake inhibitors are on the list of things that can be useful to treat menopause and menopause symptoms. I will also challenge about blood tests. Not everybody who's perimenopausal needs or is appropriate to have blood tests. So I absolutely fundamentally support massively the improvement of services in Suffolk and North East Essex for women who are perimenopausal and menopausal, not just about HRT, about their bone health, about the availability of ring pessaries, about smears, about HRT prescriptions, about ultrasounds, transvaginal ultrasounds, about a vast number of things. But I am really concerned about this presentation and the amount it says about general practice.
Thank you very much, Ruth. Points very well made. And if I may, Peter, can I hold you for one moment? Because I think Sam and Brenda, you wanted to come back with specific comments on what Ruth was saying.
Thanks. Yeah, completely.
Thank you.
So I completely hear all your points. And this is something that comes up in a lot of the engagement we do. So we go out and we ask a broad question for all open responses. People that are very aggrieved are very quick to share their views. People that have had a reasonable experience very rarely share their views. And people that have had a phenomenal experience share their views. So there is always a caveat with any engagement we do, is we can only present what we are told. And unfortunately, a lot of people who have a reasonable experience don't share that with us. So we do tend to get a lot of people who've got a strong opinion share their view. So we do try and present measure, but we can only present what we have been told. Now, I know that there are good practices out there. As a woman myself who's had huge amounts of treatment in this area and is coming into perimenopause, I've had fantastic treatment from people. I've had great experiences, but I can only share what we have been told in this report. And unfortunately, that does sometimes mean that there isn't the depth and balance that we would like.
So you can only share what you receive, but you have also written it in a very specific way, and I'm not sure who has been engaged with in order that it's completely this. But
so I can share our engagement strategy with you, not a problem at all, and I'm very happy to do that. But I take on board your comments. And if we get good comments, we definitely present them. We don't only put forward a negative view. We only put forward what we receive.
Thank you, Sam. Brenda, do you have a quick final comment?
Yes, I would just say I support Sam. We are very much dependent on who responds to us, and everything Sam said is perfectly true. In our personal response, there were some very good quotations where people had received work support, and also that they had brilliant support from the practice nurse or the GP, which, if you feel needs, we can add. Our own report, which goes online, does have some of that in, but we are very much dependent on what we hear. And what we wanted to do with this one, perhaps, is say what we felt needed to be done to improve it, rather than rather than being purely negative about it.
Okay, thank you, Brenda. And can I go back to Peter Smythe? Sorry to keep you waiting, Peter.
That's okay. I think Ruth made some, some excellent points, and I won't reiterate them. Just a couple of thoughts. I wonder whether the methodology of your sampling needs just to be thought through again. So Andy and his team quite often sit Healthwatch guys in our surgery waiting rooms, and I often find that's a better representative way of gathering the data than going and asking people about specific issues, because as you have identified, you then get the people who shout the loudest in effect, and you get a bias that way. Just a reflection on the methodology. The other thing that strikes me is that the themes that you draw out around lack of empathy, and I do have serious concerns about our GP workforce, that they're burning out, and lack of empathy is a sign of burnout. If you're on your 40th or 50th consultation, perhaps 3 or 4 of which have been palliative care patients or seriously ill children, it is difficult at the end of a day to be empathetic. I'm just being brutally honest. So that is the situation that the system has created, and we mustn't multiply that effect by denigrating our colleagues further. The other thing I would say is that this has become a huge issue, quite rightly so. So prescription volumes, number of menopause items issued in the last year is up 35% over 12 months. These are medications that need proper consultation with an appropriately trained clinician and follow-up. They are not straightforward. They sometimes require titration. That is a vast amount of work. And I come back to my original point about empathy and burnout. The system expects our practices to deal with that level of increase and in an empathetic way, and to deal with all the other things like strep A that's coming through the system. And we wonder why we get burnout.
Thank you very much, Peter, for those really helpful thoughts and comments. May I go to Shane now, please?
Thank you. I don't claim to be an expert by experience, but I have had clinical experience of treating patients, but also counselling colleagues at work over a number of years on this. And it's a huge issue, and it's hugely emotive. And I think we hear that in the words in the reports and in some of the commentary back from colleagues. I think there's a lot of this is about the perception of the information that's received. So I think some of Ruth's comments I would absolutely agree with, such as the use of drugs which were developed as antidepressants but have a role in the treatment of menopausal symptoms being perceived as GPs misdiagnosing or mislabeling the symptoms that women are presenting with. And I think we do need to perhaps put a bit of context around that in the reports, because they're there as unvarnished comments by service users, which is absolutely right. But there is some interpretation of that needs to be considered around it, which means there might be some misperception there. And that might give some comfort to clinicians who are battling very hard in this space. I think my experience, I was trained a long time ago now, but I had really good training in menopause care as a GP and would have very detailed and involved conversations. One of the things that really concerns me, though, is there is the use of the most effective treatment, which is HRT, is still an absolute battleground in medical politics. So there is the NICE guidance is terrifying on the use of HRT, and as GPs we have been browbeaten to not prescribe HRT. If you talk to the gynecologists, they will say largely that's nonsense. If you look at all-cause mortality, it's significantly reduced by the use of HRT. And we've got a bit of a kind of pharmaceutical battle raging in the background here, which is hampering our ability to offer women the most effective intervention for a condition. It's not a disease, it's part of the human condition, but a condition that ultimately affects half the population extremely detrimentally in some cases, in many cases. And we've got a great treatment for it that we don't use because there's a disagreement in medical politics. And it's difficult for GPs to fight their way through that as non-specialists. So I think some sympathy with the position that I think Ruth articulated beautifully and that Peter also articulated is warranted.
Thank you very much indeed, Shane. Mindful of time, and we have 3 more hands. So can I quickly go to Melanie? And then Nicola.
Thank you. I mean, I put my hand up because I just wanted to give a massive shout out to my GP, who, the presentation, understand that you've heard these experiences, which are terrible from women, but it is totally unbalanced. And there are a massive, great group of women who are having a fantastic experience from their GP, great care, without drama or emotion. And I just want to balance this a little bit, because I think this has really potential to land so badly, clearly with the profession. It's very unbalanced, but also with the population. And I think just got to be a little bit careful that we don't create enormous fear and anxiety with this terrifying thing that is perimenopause, menopause, and, all of these terms, when actually there is lots of information out there. There's no mention of self-help as well. And there are some excellent, there is, through the work of Davina, and then I think there's a doctor on daytime TV called the Menopause Doctor now, who has an app that lots of women are using. And there is information out there that's very clear for women, and lots of women are being helped. I appreciate it may be women in certain areas of the population, but I really feel strongly that we've just got to balance this in these circles, in these groups, and really support and call out the GPs who are under enormous pressure, who are doing a fantastic job.
Thank you very much, Melanie. Here, absolutely. Points very well made. May I go to Nicola now, please?
Thank you so much. It's a fascinating conversation, isn't it? And of course, there are multiple perspectives on this, and that's part of the point. I just wanted to make a point about equality, diversity and inclusion in this space, because we are talking that so far we've talked almost exclusively about women and used that language. And I know that this is a sensitive area, but trans men, non-binary people and intersex people also can experience menopause, and therefore we shouldn't be exclusive in our language. We need to think about that and pay attention to that. And having said that, which I think is important for us to think about, this is wider than the menopause as well, because this is reflective of structural sexism and marginalisation of people from certain groups within medicine and within people's experience of healthcare. So I think it's important for us to reflect on that as we think about the strategy and implementation of the strategy, as to how do we address that as a system? How do we recognise that? How do we make sure our research and our methodologies reflect that situation? And then my final point was about menopause policy, and thinking about what various organisations might have, and just thinking, wouldn't it be great if we had one menopause workplace policy across the ICP or the ICB that organisations could sign up to, rather than everybody coming up with their own, and actually use the strength of this partnership to push that forward.
Brilliant ideas. Thank you so much, Nicola. I think we'll probably want to come back on some of those in a moment. But could I go to Joan, apologies, and then Ed?
Is it me? Sorry. Yeah, I was very much echoing that last point, really. I'd just like to thank everybody for the debate. It's been hugely educational for me. The 35% increase in prescriptions, that I find that a terrifying number. Of course, I don't know whether we are going back to a restoration of a pre-COVID number, or whether it's a good or a bad number, actually. I just always think an increase of that sort needs inquiry. But it's just in line with the last piece. I find myself reflecting on our approaches in our workplace and what that said to me about the understanding that people have of the needs of others around them. And it's in that workplace that I was focused.
Wonderful. Thank you very much indeed, John, for that. Joan, and then Ed.
Hi, Amanda. Thank you. Thanks. Really interesting debate. I was just wondering whether adding in some examples of really good practice into the document might be a way of just highlighting how some people are dealing with this, because there is some really great work out there in the workplace and for people individually. So it was just a suggestion really about how the report might kind of help raise some awareness and examples of good practice really.
Wonderful. Thank you, Joan. And Ed?
Yeah, I mean, really important we've brought this here today. I think there's a start of a conversation, isn't it? We've got a very long way to go. My question was, I wonder whether there are any connections or relationships we could build with our local universities here to support us on this. It would be great if we could, develop a sort of centre for absolute excellence in this area. And I wonder whether kind of that educational support might be another kind of piece of the jigsaw we could look at, Amanda.
Completely agree. That's a really good point. Thank you, Ed. We can obviously take that forward without question. Thank you. Andrew?
Yeah, I mean, appreciating time. Just very briefly, there seems to be an absolute need to respond to this feedback, isn't there? I always like unfiltered patient feedback. I think it's where the real truth lies. Of course, you always have to assess, is it balanced or not? But it doesn't matter. In some ways, it was unfiltered for these people, and therefore we have to accept it as it stands. I don't disagree with other comments about increasing panic or creating a misperception inadvertently. It'd be good if we could give some thought to that, but appreciate that wasn't the purpose of this report. The purpose was to feedback what people told you. I've already been thinking about doing some work in the new year, and I'd spoken to some colleagues, not just on menopause, but on the women's health strategy, and apologise, Nicola, for calling it that, but that's what the government called it, and I can't think of a better way to describe it at the moment, but very much taking your points into consideration as well. We need to think about the language we use in this. There are all sorts of issues that affect women disproportionately, not just including menopause, but also cardiovascular health, MSK health, independent of osteoporosis, weight, diabetes, etc., etc. So there's a real need to look at the inequalities in 50% of our population and how we manage that as an ICS. And I would just like to suggest that we dedicate some thought to that as a partnership next year, and provide some thinking on actually how we manage that inequality better.
Superb. Thank you very much indeed, Andrew, for that. And may I go to Andy now, please? Andy Yacoub.
Thank you. I've got a few things to say. First of all, I don't believe I've heard menopause, perimenopause mentioned at either the ICS or the former Sustainability and Transformation Partnership before that in the last 5-6 years. It started appearing in social media and also in some feedback that we were receiving, which is one of the reasons why, as to Health Watch, we decided to ask the public about their experiences of it. Normally, when we present reports, more often than not, we'll get some nods, we'll get some recognition. The reports tend to be pretty balanced, and we move on. On occasions, there's something within the reports that causes the system to react positively and takes action. On this occasion, prior to arranging for this to take place today, I did also ask that the GP Federation in Suffolk were invited to present their survey, because as I understood it, GP Federation were also conducting a survey around menopause and perimenopause, because I wanted that there as well as a perspective. But what I've heard today is very clearly an indication that, and Shane was the first to mention it in chat, that half the population have something to speak about that we haven't been talking about. And if anything else, this should lead us to do something really major over the next couple of years. And it's crying out for a collaborative piece of work, a co-produced piece of work. So I hope we get that as an action from today. Thank you.
Brilliant. Thank you very much indeed, Andy. And I think what you've said is absolutely captured. Now, Pauline, you did have your hand up. You've put it down, but I note you've put something in the chat. So we will obviously follow that through with you. Absolutely. And I think then that leaves just Sam and Brenda. So Sam.
Yeah, this is fascinating and a great debate, because we, as Andy said, we don't get this kind of feedback normally. And I tell you, if we get a wave of positive responses coming in about good practice that has been had, that would be a fantastic "you said we did" piece to add after this, to say, okay, so we put this out and look at the swathe of positive information that came in, and maybe this will provoke that cohort of the community to share a really positive story, because we would love to have a lot more balance here. But I just will not filter or only present positive news that comes in. We were once approached by an organisation to say, can you present good news stories on a topic? And both Andy and I said, we will ask the question and we will share the feedback we get. Because that's what we're here to do. We are here to give a platform to the public to be able to share their views. Sometimes they're positive and sometimes they're not. We can only present what we are given. Take the point about people that was involved in the engagement methods, but I'll make sure that's reflected in anything that goes public. That's a really valid point. But yeah, just to say, we would love to get some positive stories in and add a second to this. But in the 2-month engagement phase for this piece of work, 97 people wanted us to interview them to share their stories. And that's more response than we've got on any of the other surveys. And we do 2 of these a quarter.
Wow, brilliant. Gosh, thank you, Sam. And final word, Brenda, before I hand back to Will.
I would just iterate what Sam has said. I think we had a few positive, but there was so much in the minority that we can actually add a slide to it and say these were the positive comments, where people did have amazing nurse practitioners or amazing GPs, but there was so few that the majority actually said that. We had actually 427 responses to our survey across Suffolk, which was actually the largest response we've ever had. The majority of them were actually just saying what we have put in the report. If you like, we can add a slide which said what worked. And when it worked, it always works. It's brilliant when someone finds the good service. It's all about education, and people at an earlier age need to know about it. And Dr. Galloway was right. I always tell all my friends, all my younger friends and family, HRT is the answer. Forget about what they tell you, the risks. I looked at the risks 30 years ago, and I decided I would take the risk. And I think that advice still holds dear. And I would go for HRT any day of the week, and advise all my friends to do so and family to do so too. So I would just say that. But as I say, when the advice is good, when the support is good, it really is good and helps women through. The majority of the feedback we got was what was in the report, and which is all we can say.
Thank you very much indeed, Brenda. Now, we're going to pause in a second. I'm going to hand over to Will in a few seconds, but by way of a quick summary, we've captured a lot of rich next steps in the chat, which we'll come back to. But I think at this moment, Will, I'm handing back to you.
Thank you, Amanda, and thank you all. That was a really powerful debate, and actually, on a personal level, I learned so much in so many different ways. Thank you all for the hugely rich debate. However, I'm going to just put a meeting chair hat on now. We're 4 minutes behind our break time, but we're an item. We've got some work to do. I've also got a little bit of management to do in terms of making sure we are not late for the 2 approval items that are towards the end of the agenda. So what I'm going to do is suggest we take a break now till 11:20. Get away from the screen, have a walk, stretch the legs, usual thing, cameras off, microphones off. When we come back, let's deal with the leading for system change approval with Alison and Amanda, and then the ICS quality strategy approval with Lisa. That, fingers crossed, I wonder if we can take those as read and go straight for approval, but I'll encourage colleagues to just highlight if there is anything they need to. And then we'll come back to, we've still got 2 items in this focus on menopause from Ashley and Ruth, and then Amanda's own item on the workforce. Remembering that this is a whole system challenge. It's not just as we've talked about so well already. So that's what I'm going to do. We're going to break now till 11:20. We'll come back, do those 2 approvals, and then back into menopause, which will be followed by maternity. But we're going to have to move quickly and sharply, as always. But having said that, what a powerful debate. This is what integrated care partnership is all about. Thank you very much, all. Hello, everybody. So 11:20. Hope you managed to stretch your legs and get a drink. What I'm going to do now, in the interests of expediency, of course, and meeting management, as I said before we had a break, I'm going to go now to the 2 items for approval, which are towards the end of the agenda. We do have the colleagues in the meeting for those items, which is useful. Well, essential, of course. And I just wonder, I don't want to ask you to do something you shouldn't do. This is Alison, Amanda, and Lisa. I don't want you to encourage you to do this incorrectly or wrongly. But if it's possible to go straight for questions and then for approval, I'd encourage us to do that if we can. But let me go to leading for system change. Amanda, do you want to kick off with this one?
Indeed, thank you very much, Will. So I'm taking the paper as read, but I'm really excited by this potential opportunity because our dear colleagues within the Leadership Academy have been supporting other systems and shared their learning to date with us in Suffolk and North East Essex. And from speaking with Alison and her team recently, I felt it was such an amazing opportunity to be working with the Leadership Academy for the greater good of our system in terms of developing our future capacity and capability by creating basically a cohort of system leaders. And I think I would want to underscore system. So I think we are very well placed in SNE. I think we have the right kind of can-do attitude to really embrace the offer that Alison may want to allude to in more detail, but I think, you know, we have such an opportunity and it would be a missed opportunity if we didn't really embrace and want to develop our future leaders of tomorrow, Will. So that's all I'll say by way of summary at the moment, given time.
Thank you. And then Alison, would you like to add anything to that?
Thank you, and thank you for the invitation to attend. I'm Alison, and really grateful to come here today and listen to your discussion. I think all that I would add from Amanda's introduction, that this is a systems leadership programme. It speaks to much of the content today. It is about how do we equip leaders and managers with the skills to collaborate, to work collectively around difficult areas, to co-create, to think differently, to work within a systems mindset. It's also very much an experiential learning. During the programme, those cohorts will be asked to look at some of the complex or wicked issues that you would select as an ICS. And alongside that learning, we'll be focusing on those types of areas. So the added value of doing by learning is that when people learn together, they connect, they create relationships, they create trust. And I've heard very strongly, you know, throughout this meeting how important those aspects are as well. And our learning from other areas, it is also the system then takes forward. It's not that these are complex issues. It's not that you'd expect over the duration of the programme, such as 6 months, that they would be completely resolved. But actually the commitment and senior level sponsorship across the system enables that to continue, that work to continue. And it's very much pan sector and pan organisation. And I'd reflect on the menopause conversation. Actually, I'm not saying that that should be one of the areas that is looked at, but if you think in that discussion, I heard self-care, digital, patient representative organisations, local populations and communities, NHS and private sector, education, GPs, you know, a real pan sector community issue. And even that discussion demonstrates it. It's not simple, is it? All the barriers that could be in the way in terms of improvement, burnout, national guidance, drug supply, you know, all these things make it very complex. It's not that we can just go away and make that better tomorrow. So actually enabling people to come together, learn together, but perhaps try and focus on some of these complex issues is really the added value, I think, of this programme. It's fully funded. It's for around a cohort of 40 participants. It takes around 6 months to complete. We would look, obviously, from your endorsement as leaders within the system, support to release staff from service. That can be very difficult, particularly during these challenging times, as you know, but commitment to support participants kind of throughout the programme is really key. I think the rest of the points are probably clearly explained within the paper. So really, I think Amanda and I are here looking for your endorsement to continue. We do support with faculty and also within my team to continue to work alongside you to ensure that the programme can be delivered and is impactful for the participants and for yourselves as a wider system as possible. So are open to questions.
Thank you, Alison, and colleagues. I can see hands already coming up, but I do implore you to be brief, please. Nikki?
Okay, I'll be as brief as possible. Thank you so much. I think this is really exciting. I took part in a similar programme in Norfolk and Waveney, so can absolutely recommend it. I wondered if we could think about the participants and our challenges around EDI and senior leadership in this space, and potentially sponsor individual-specific groups to address some of the barriers that we have to progression for people from the global majority. So if we could do some targeted sponsorship, please.
And I saw Alison nodding as you were speaking, Nikki, so we'll take that as a yes. Shane?
Great, yeah, love the Leadership Academy offers. They're usually very, very good, would strongly support us engaging with this. There is a paragraph at the end of, I think it's page 7, that says it sits alongside our other existing leadership offers. What I don't quite understand is how it integrates with those. And I think Nicola's suggestions around, targeting underrepresented groups of staff so that we invest in their development. I love it. Brilliant suggestion. Thank you.
Okay, and again, I saw Alison nodding, so we'll take that as a yes. Thank you, Shane. So, colleagues, for approval, let me just go straight to the point. Anybody against? I see no hands raised. Shall we take that as unanimously approved with great support from the board? Thank you. There's one action, Alison. Shall I mention it for you? You wanted 5 wicked issues and wicked issue suggestions from people today. We don't have time to debate it today, but Alison, would it work if we ask all colleagues to send the wicked issue suggestions in via the perhaps via Susanna and the team, so that they can be forwarded on to you? And it would be very helpful if you had them for before the 21st of December, I suppose, when you were taken to people. Yeah.
If possible, and then I'd perhaps suggest with myself and Amanda and Susanna, we sift through those and kind of look at what seems to sit best in terms of the learning and the approach and what works for you as a system.
Oh yes. I wasn't guaranteeing that any wicked issues sent in would be adopted. Yes, otherwise I'd get myself into trouble there. But yeah, okay, colleagues, thank you very much. Ian and Alison and Amanda, thank you for that. Let me then move us on to the second approval item, the ICS quality strategy. And again, Lisa, over to you, but if there's a way we can go straight for questions, that would be great.
Thank you. I'm very happy to go straight to questions with just a couple of minutes from me. If we couldn't go straight to questions, this would have missed the point, really, because the whole point about this strategy, the thing that people asked us to do through months and months of discussions and negotiation, was to keep it simple, accessible and jargon free. So you may see it written in a slightly different style and to other strategies, because the most important thing for this strategy is that staff from all disciplines, all professions and all areas, whether they're working directly with users or whether they're in leadership roles, can understand what we're trying to do. I just need to firstly apologise around the logos page. So I don't know what's happened to the rest of the logos, but they seem to have slipped off. So please, before everybody rushes saying we were involved, we have worked with many more organisations than those that are on the logo page. So I will make sure that is addressed before we publish the strategy. So the strategy's been approved by the steering group. The steering group has been representative of health and care organisations across Suffolk and North East Essex. We've had lots of conversations we plan to use the quality management system as the real kind of lever for how we work on the delivery plan. It will be overseen through the system quality group, which meets next week. And apart from that, I'm happy to take questions. Will, thank you.
Brilliant, Lisa. Thank you very much. So, colleagues, any questions for Lisa? I've got Nikki. Yeah.
Thank you. It's not so much as a question, but just 2 points. One, I just want to say that Lisa has worked really hard to be inclusive in this paper and has really reached out to partners to be involved. So thank you, Lisa. The second point is really about co-production, and the point is made in the paper that there wasn't really the opportunity for co-production with communities and with real people, but the delivery plan aims to achieve that. And I think it's really important that is how we push forward with it in that spirit. So thank you.
Okay, that's great. Thank you, Nikki. Point well made and taken. Thank you. Ed.
I'm very supportive of the strategy. I'm just conscious of Nikki's challenge at the start of the meeting around language, but in this you've achieved a sort of a common language which I think everyone can read and support. So it's just how we learn from this process for future documents, because we often lapse into kind of partial language, don't we, around patients or clients or whatever the term is. So kind of this as the first example, I think, of a really kind of system language document that we produce. We need to do more of this.
Yeah, that's a good point, Ed. Well made. And actually, maybe we need our own lexicon, our own language. Why don't we? Because I know everybody's got nothing to do, and you're dead quiet, so you'll appreciate the suggestion of making our own lexicon, and we have our own SNE language, because actually it is important that we talk to each other in those same languages, isn't it? So thank you for that. Let me go to Shane and then Susanna. Shane.
Thanks, Chairman. Just on that last point, I think English works. Plain English will be quite satisfactory. I think it's a great document, really well structured, easy to read, but I'm still left at the end of it thinking, how will we know if it's working? I get the bit about what we want to achieve, but it's in generic terms. There's nothing specific in this strategy that says we're going to go from here to here and this is how we know we're getting there. And therefore it feels it's going to be really hard to put this strategy into practice and know that it's doing what it says on the tin.
That's a good point, Shane, and one you often commonly make about measurables and assessment. Lisa, do you want to respond to that before I go to Susanna? Because I'm just wondering if we could get approval. This is a question for you and the whole board. If we could get approval for today, maybe measurables could be added, maybe, but leave it with you.
No, I think that's a really good point. And it is one that we talked about in one of our last meetings, actually, is we definitely need to do that work around being clearer and defining it. I think Nikki was brilliant in her challenge to us and was incredibly helpful. But one of her challenges that I remember was, can we just get on with it now and stop talking about it? Because we have spent a lot of time talking about it. But I agree with Shane. We do need to take that need for being much clearer and defining what it is that we want to do, which is why we want to use the quality management system as a framework and put our money where our mouth is, so to speak, and actually work through what are those definables and what are those things that we want to do. So does a strategy have to be a completed thing? Can we come back and update the strategy as we go along? Because I think this is going to be, I think when you're trying to work across so many organisations and so many people, I could have probably spent the next 4 years on this piece of work. And I think there had to be a point where we said, that's enough, we need to approve it now. But I think we'll need to keep coming back to it almost and saying, well, actually, this is how we feel now.
Yeah, that's a good point. And also, we shouldn't let perfection be the enemy of good, should we? So maybe perhaps we'll suggest to board once we've had all the questions, perhaps we could approve today, if the board is so minded, with an update, a piece on measurables to come in 3 months' time, or whenever. Okay, let's go to Susanna then.
So I agree with everything else said, and congratulations, Lisa, and everybody, because it's a brilliant piece of work and it drops neatly and perfectly timed into our ICS strategy as well. Just an offer, which is obviously why you've been doing this. We've been out kind of just asking that very general question, what matters to you? And as I keep saying, a lot of the things that people have told us and, what we've captured relates to quality, relates to a lot of the issues that the strategy talks about. So I wonder whether one of the next steps is for us to kind of help, rather than going back and asking people again, is to try and help filter that stuff and organise it in a way that it can inform maybe further the work that your group are doing. Because I think there's a lot in there, and maybe we'll find some of that voice. And going back to the earlier point I made about strategy, some of the areas where we might need to think about, well, how could we measure that? That builds on Shane's point about how could we measure progress. So I think we can bring the two together now with perfect timing, as if we'd always planned it that way.
Okay, thank you, Susanna. I'm going to take that as rhetorical, Lisa, and you agree with that. Good. So, colleagues, we're being asked now to approve the paper as presented, but noting that it's a work in progress, a continuous improvement, as all strategies are, and that specifically we'll ask Lisa and team to bring back a further paper, an update, a proposal on measurables and how do we know we've had impact and how do we know it's working piece, as Shane articulated, in, say, what would be reasonable, Lisa, in 3 months' time, do you think, or is that unrealistic?
Can we, so I'm just thinking about the amount of pressure that people are under at the moment, and the ability for me to get people around the table at the moment. I'm happy to go with 3 months, but if you'll be patient with me, if it's not ready in 3 months, well,
look, why don't we say the April meeting?
Okay, yeah.
Okay, happy with that. So, colleagues, okay, anybody? Let me do it again in hopefully a quick way. Is anybody against? And I see no hands raised, so we'll take that as unanimously approved. Thank you very much, everybody. Okay, so back to the agenda as was. Amanda, I'm going to come back to you now for the focus on menopause piece, and you've still got 2 papers in there. Ashley and Ruth, and then yourself. Colleagues, we're going to have to be still prompt, though, if we're going to finish on time, which is, we always finish on time, don't we? So, Amanda, over to you.
Thank you very much indeed, Will. So back to our second item on our menopause section. So can I invite Ruth and Ashley to present, please?
Yeah, of course. I'll just get the presentation shared on the screen for you.
And can I just thank Ashley for stepping in to do this, because it's this first-time speaker, so everybody be kind.
Sorry, it's just loading. I'll be with you in a moment.
So while we were waiting for that to load, so just a little bit of background. So Ashley works within the Suffolk GP Federation cervical screening team. There's 2 sources of funding into this stream to improve the uptake of cervical screening in 2 groups. One, those who are less likely to access cervical screening, and then secondly, those high risk. And the team has done a phenomenal amount of co-production work and design of this with those patients. So over to you, Ashley.
Yeah, so thanks, Ruth. So just a brief overview of the project. So we do work alongside the Cancer Alliance to increase both the uptake, understanding and importance of cervical screening. It has become evident that menopause is having an impact on patients attending their cervical screening. So what we have done recently is collated a survey to address the barriers and look at the reasonable adjustments and support that we can offer. So yeah, we are a co-production project working to reduce health inequalities and increase cervical screening in Suffolk. We work with primary care, extended access services and the community to support the uptake throughout Suffolk. So moving on to some of the questions that we did ask in our survey. So one of them being, have the symptoms of menopause affected your vaginal comfort, i.e. discomfort during sex, discomfort when being examined, discomfort when passing urine? So these were the results that we did receive. 80% of patients have advised that they have experienced some discomfort when having their cervical screening or whilst being examined. Some patients said it was painful when having sex, general vaginal discomfort, very dry, and some patients experiencing burning sensations. We are aware that cervical screening can become painful during the menopause. There is lots that we can do to support patients, and we want to break down the barriers to support patients to attend their screening. So the next question that we asked was, have you spoken to a medical professional regarding this? So
Actually, sorry, I'm aware that because of me, we're running late. So if you just read the top bit and then let everybody read the other bits, is that okay?
Of course,
and then you'll know.
Absolutely fine. No worries. So have you spoken to a medical professional regarding this? So I'll leave that up there for a couple of moments.
Okay.
And then the next question that we asked was, have you been offered any vaginal estrogen or vaginal moisturiser prior to a cervical screening, such as Vagifem or Replens?
So only 40% of people had.
Just talked about inclusion. This doesn't work for a blind person. I'm sorry.
Oh, I'm so sorry. So 40% of the patients had been offered additional support and moisturisers.
Okay.
Yeah.
Next.
So if you have not yet spoken with a medical professional, what is stopping you from doing so? So fear of judgment, embarrassment, and not wanting to bother a medical professional are common responses that we did receive.
And also it was difficult to get that appointment.
Yeah. So what more could be offered to support patients going through the menopause to enable you to attend an appointment? So some of the things that we offer are our extended access clinics. So our GP Plus clinics, they're evening and weekend appointments. In the evening, we offer appointments from 6:30 till 8:30, Monday to Friday. And then on a Saturday from 9 a.m. till 4 p.m. We offer appointments as well. We give patients the option to meet with a clinician prior to their appointments. They can discuss any concerns with them there. We are looking to explore options for more standalone clinics with gas and air to cut on colposcopy referrals. And we have also supplied menopause specific posters and materials to primary care as well as part of our project. So yeah, we want to encourage more open conversations regarding the menopause to ensure that patients feel cared for and heard, and just to be confident to speak to patients about the menopause and be aware of the signs and symptoms. We will just say, if you do work in a practice in Suffolk and would like some further support, our health educators can help. So please do get in contact with us. Our contact information will be at the end of the presentation. So here are some of our top tips. I will leave them on the screen for a few moments, but again, we can get them circulated out for you.
And the highlights are using a smaller speculum, using water-based lubricants on the speculum, much more so than usually, trying a vaginal moisturiser before the appointment, and then discussing HRT or a local estrogen, which will need to be prescribed. So that will need to be a discussion with a prescriber. So, sorry, Ashley, that last bit on that last slide, and it isn't just a vaginal dryness. The menopause can cause other symptoms which might make cervical screening more difficult. Anxiety is one of the mental health things, but also depression and and others as well. So go, Ashley.
Yep, so we have a list of reasonable adjustments, and them being having a couch that is in the correct position for patients, which can adjust. We also offer longer appointment times, pre-screening appointments, again, where people can meet with a clinician prior to their appointment. We send out pre-screening questionnaires. We offer chaperones, a range of different speculums, and estrogen and vaginal moisturisers. These are some of our grounding techniques. Again, I will leave them on the screen, but we can get them circulated out after as well.
And this is things like relaxation, so breathing, melt into the couch, use your muscles, repeat that, breathe again, and yeah, some focus on breathing. Next, good.
So how can we support? So we have access to language line if required, and access to cervical screening leaflets in different languages. We actively invite patients, so we call them and speak to them to see if there's anything we can do to help make their appointment more comfortable and encourage them to come and get their screening done. We do a lot of work on social media. We post a lot of information on there, things like our clinics that we have available for the week, and keep people up to date of what events we are attending so they can come along and speak to us if they wish to. We have a variety of different display posters. We've supplied these to primary care. Again, we post them on our social media, and we do have some available on our website as well. So we're trying to make screening more inclusive. So one of the changes that we have made is moving from the standard pink paper to yellow paper, because we found that this was the best colour for people with a visual impairment. We offer additional support to patients after their appointment once receiving their results. So if they wish to discuss anything with a clinician, they can. We do say patients can listen to things such as music or a podcast if they wish to. We always make it clear to patients that they are in control, and that the examination can stop at any time and they do not have to proceed. We also send out leaflets with invites, and we also have easy read and translated options available. Here are some more helpful links. We will make sure that these are circulated out after the meeting if anyone did wish to read through any of them. And this is our social media and contact details. Again, we can get that circulated out for you. And yeah, thank you for listening. And again, just to extend our offer, if we can support you in practice in any way or the community, then please do just get in touch with us.
Wonderful.
I would just tail that. Thank you so much, Ashley, and thank you to the team. This presentation is specific to menopause. There's some other amazing work that the team have been doing with transgender patients with people who've experienced domestic violence and various other groups, and this has been done with those groups. So I'm very proud of the team. They work very hard to do this, and this isn't done. There will be additional things that will come out of this, and additional things such as the team working with our ultrasound team. So learning that we've developed on menopause and transgender, we've shared with our ultrasound team because it's relevant to them. And wider issues that come out of this.
Great, thank you very much, Ruth, and indeed Ashley, a brilliant presentation. I've learned a lot from just a few moments listening to you both. So we have a few moments before I present my item. So colleagues, do we have any questions for Ashley and Ruth, please? I see no hands, so I'm taking no hands as support of the information that you have shared with colleagues this morning. So I see some nods, so thank you very much, everybody. So moving on then to the final section of the menopause section, this was basically a paper from one of my dear colleagues, Debs Crelly, who actually leads our health and wellbeing team across the system. So I'd like to, if you don't mind, just put into context where the health and wellbeing team sits within our governance as a system. So we've had the system health and wellbeing team across Suffolk and North East Essex for probably 18 months now. And the health and wellbeing team report into a collaborative which is chaired by Fiona Ellis. And Fiona has been doing a great job with system colleagues over the past year on bringing together all things health, wellbeing and recovery. That collaborative reports into our people committee. So we meet as a people committee every couple of months. So through the work of Debs Crelly and her team, and indeed the Health and Wellbeing Collaborative, they have done a lot of work on menopause support and what that means for our health and care staff. And they have created a menopause support network, which currently has something like 400 members made up of GPs, consultants, community staff, volunteers, nurses, and the like. And that through that network, they have created My Pause. And through the My Pause work, they recently applied for accreditation on the great work and training that they have been doing to support our health and care staff on all things menopause related. So they applied for accreditation from handpicked menopause accreditors, and they had to basically go through 6 standards of evidence, collation, interviews and the like. And through that accreditation, they, as a network, and we as a system, have been awarded a rare level 5. And I think that is something that we should all be immensely proud of. Some of us may know that, some of us may not, and it may be that one of our actions from today's conversation is that we do further communication across the system. But what that basically means as a handpicked accredited system for all things menopause means that we can tap into policy, training, development, and we can also, if we choose to, as organisations, use the menopause friendly employer logo on our recruitment and literature going forward. So that's an opportunity and something that we may consider as a system and indeed as individual organisations. But I think in summary, and through the paper that Debs Crelly has presented today, I think it is really an accolade of the great work she and her team, and through Fiona Ellis, through the collaborative, have done to really step up and look at, as a system, what can we do to support our workforce? What more can we do? And what more can we do coming together to actually share where we've been to, to date and everything. And I think that paper brings in the other 2 presentations that we've had this morning. And I think collectively, there are a number of actions that we can take from those 3 items. And for me, in summary, bearing in mind the time, I think there is opportunity to look across the system on doing things once. And I know, Nicola, you made reference to having a system-wide menopause by way of policy, by way of an example. And that's something I will discuss with Debs Crelly and her team and build on the work that we've already done. I like the idea of having a centre of excellence. And Pauline, thank you very much for your offer in the chat earlier on. I think there is definitely opportunity that we can do there. So I would very much want to link in with you and your team going forward. And I think through the Health and Wellbeing Collaborative, it may be a good idea that we can link Debs and colleagues into yourselves through Health Watch Suffolk and Essex, so that we can join up all of the dots and links so that we have a conducive one offer on all things menopause across the system. I think we've done a lot. I think there's a lot more we can do. And from the conversation this morning, I think there's some really rich, pragmatic, tangible examples that we can take forward. So a big thank you for me. we've captured in the chat a lot of actions previously, so I wasn't planning to go through those again, Will, but I think we have captured, and we will make sure that we weave those into our agendas going forward. So that's really all I wanted to say, Will, but very happy to pick up any further questions given we've got a few minutes to go.
Excellent, thanks. Actually, there's one in the chat from Shane. Shane, do you want to just make that point? Because Amanda may well know the answer instantly.
Yes, I'm not aware of what Henpicked is, Amanda. Is it? It's but just Googling it suggests it's a social networking site of some sort. Is that right?
Yeah. Well, yes and no, but Henpicked is a bit like Investors in People as a national accredited organisation. And they actually apply a methodology on assessing organisations against a number of standards with regards to have we got the right level of support and the like. But I'm very happy.
Who are they accredited by?
I will need to double
check.
Let me take that as an action, Shane. I will double check that. But I know that there has been a lot of work undertaken with them by the team. But I will definitely take that forward.
Yeah, it sounds great. It's just that, you know, if we're going to plaster this all over our organisations, I'd just like to know the provenance of the accreditation that we're getting.
Of course. Thank you.
Okay, good. Any further questions for Amanda? Shall I take the chair back, Amanda, given that you're the one now who could be answering the questions? It's always tricky to monitor the questions and answer them yourself, isn't it? But any questions for Amanda, or indeed Ashley or Ruth? Don't see any. That's been a great item, I think. A really rich debate, and the fact that we can have, that we want to have, and that we do have these difficult and complex in so many different ways, complex in just so many different ways across every matter of the way we work. I think the fact that we can have these debates is really, really important, and actually is to be honest, it makes me feel proud, not because of the specific subject matter, but because of the team which you are having the debate that is needed over difficult subjects openly, transparently, fairly, empathetically, compassionately, supportively. That's exactly what we want to do. So thank you very, very much all. Okay. I'd like to move us on then now. Remarkable. Actually, I was going to say, trouble is, I was going to say something and I've told you I was going to say it. I've got to say it now, haven't I? We're actually dead back on time now. Thank you all. It's a miracle, isn't it? But that doesn't mean go slowly, guys. So I'm going to hand over to colleagues for the next item, the maternity and VCSE partnership working item. Now, I was going to go straight to Helen and Terry and ask Ed to comment after the meeting, but I know that Ed's got another commitment which is very burning, and he will have to leave this meeting to deal with. So Ed, would you mind if I asked you to do an introduction and then I can go to Helen and Terry?
Yeah, sure. Just a few words of introduction. So, I mean, firstly, pay tribute to Helen and Terry. They're doing great work in terms of promoting equality in the context of maternity. The paper particularly looks at how we've worked successfully with certain voluntary sector organisations to support people on the maternity pathway. And behind the scenes, we're developing conversations around how we can build in that that voluntary sector support in the longer term. And we'll be working with West Suffolk FT and ESNEFT on that. So I just wanted to provide assurance that there is a real commitment to get that recurrent investment into the voluntary sector in this particular context. So that was all I was going to say, and hand over to Helen and Terry to talk you through the specifics.
Thank you, Ed. Thank you very much. And Helen, all yours.
Good morning, everyone. My name's Helen Bowles. I'm the local maternity system programme manager. My colleague Terry Gavin-Jones, who is the clinical lead midwife for the programme as well. And as Ed kindly said, we just brought a paper today, which I'm assuming everyone has read, around the work that we've been doing with the voluntary sector around maternity and how we can improve outcomes and service experience. So this came about from a number of avenues, really. Andy and his colleagues within Healthwatch did a huge piece of work on patient experience or service user experience from maternity services, which created 4 pillars of feedback around their experience. We also did a engagement piece of work to create the LM&S strategic vision for the next 5 years. And also Terry's done a massive piece of work around our equality strategy, equity and equality strategy, again for the next 5 years. And you'll see in the report that people from diverse and deprived communities are much more vulnerable to poorer outcomes as a result through pregnancy. So Black women are 5 times more likely to die through maternal death than a white woman. And also deprivation is one of the most commonly seen causative effects on some of our complex pregnancies and preterm births. So we wanted to work with our community to see how we could improve that. And Terry set up an equity forum within maternity services, and there are about 60 organisations that regularly attend and feed back to us. And what our Black and brown women were saying to us: stop talking about the statistics. We know the statistics. What are you going to do about it? So what we decided to do was invest some of the maternity service development fund to ask voluntary sector partners to come forward with ideas of how we could collaboratively do something, of which we supported 6 under 50k per organisation for a year input with us, and they've made amazing impact. We're at the process of trying to quantify some of that, which is quite difficult because the schemes are very different, and the impact is very much about service user experience and trust developing between those service users and the NHS who provide midwifery. So we are absolutely in progress on doing that, and so I haven't got a presentation with graphs or numbers to share with you. But we know from individual service users' experiences that and how we are starting to develop our services, that these are making such a massive impact. And they are also showing to us something that we already knew, but I think really just reinforced to us that when we talk with all of the voluntary sector organisations about the support that they're giving to women, pregnant women, the top 3 things that they are helping and signposting them are around financial advice, where their local food bank is, and for the majority of the organisations, social isolation. Now, interestingly, the Phoebe and AFI UK, who are working mostly with our Black and brown ladies, social isolation isn't one of the top things that they are needing to provide support, because their community is very much wrapped around that woman. And Terry's done a huge amount of work with elders in the community as well, and educating them around pregnancy and how we can support women. But it then reinforced to Terry and I that also, so how do we connect our work within maternity, within our alliances, how do we connect with our integrated neighbourhood teams and bring our community assets together to support prospective and new parents? So we would love to have some feedback from yourselves around how we can progress and take this partnership working forward, what opportunities there might be. And as Ed said, he really has been helping us to try and look at how we can find some substantive funding for the schemes. But we also want to think about how we can use the learning from them and make sure that all communities across the ICS receive this type of input, because it was very self-selection and organisations bringing themselves forward, there's not an even spread across the whole ICS. So we need to do some work, particularly in the West, so that how we can bring some of the learning across. I think that's all we wanted to say, Terry, is it? And open to debate in terms of how partners feel we could take this work forward together.
No, that's absolutely fine. Thank you, Helen. Terry, did you want to add anything?
Only to reaffirm what Helen has already said, but this project is really important, and we've heard a lot today about measuring and evaluation, and actually our project is about relationships and building that community. What we are hearing from the groups that we've worked with is that their trust is low in maternity services, and maternity services are doing their utmost best, but there are people in communities that we had no idea were there, and cultures and beliefs and spirituality that we had no access to, that these groups are giving us. There's, Helen's talked about the stats, which are vastly important, but we are an outlier for premature births. We know that these communities are affected by stillbirths, but yet there are still women and pregnant people in those communities that are not accessing early maternity care. And that's often because they believe that they can't access it at 8 weeks, because that's not originally where they come from and how the service works. They also, a lot of the time, are here not on a visa of their own, but on their spouse's visa, and are very mindful that they sometimes don't have the correct paperwork and they feel that they will be charged for maternity care. And all of this goes towards building those really crucial relationships as a midwife that I need with somebody who's pregnant, to be able to say you can access care and it will be free to you at the point of access. So the work we're doing is really crucial in building those relationships. So some of the hard measures will come, but our soft measures about building relationships and creating trust are vital moving forward. And we know one organisation, African Families in the UK, we've only been doing this for 8 months, and they started recording the amount of people they've seen. And just from April to September, they've supported 173 adults and 151 toddlers. And that's an enormous amount of people for us in that community that we are then disseminating those messages to.
Yeah. No, good points, Terry. Well made. And of course, the other advantage here is get this right now. You get it right for generations, don't you? And this is the investment in the future, isn't it? Okay, excuse me. I'm going to ask. I'm going to use part of one of Terry's early comments. Actually, is a good segue into a point that Shane has made and has made before. But Shane, do you want to comment on the scheme review section and your thoughts around whether we should do this in all schemes?
Well, I'm mindful of Terry's point that the thrust of what the report is saying and the work that's being done is all about relationships, and it absolutely is. But in terms of tracking what you've done in a project and showing that you're going in the right direction, the care and thought that's put into the scheme review says, okay, this is about relationships. Can we show how many people we've engaged with and created relationships with as a proxy for, are we doing the right thing and going in the right direction? And it's just so well structured from what we set out to do, who we set out to work with, to what we actually did, and then where do we go next. It's a brilliant post-project evaluation on a page. And if we did that for all of our projects, surely we would move further forward faster.
Yeah. Okay.
All credit to Helen Bowles, who is a project genius.
Absolutely. Hats off.
Thank you.
Nicely said, Terry. Well put, Shane. And should we take that as a point noted and supported by the ICP for actually all our colleagues? So thank you for that. I'm going to go to Andy and then to Susanna. and then Kirsten. Andy, you know of a Health Watch England campaign. Can you just mention that, please?
Thanks, Will. Yes, it was launched a couple of months ago, I think, by Health Watch England. It's simply about mental health for anyone in pregnancy, and in the lead up to birth, and probably and after that as well. So if there's and we're supporting it, as is every Health Watch in the country. So if we can share this and get as many people to respond to it, Health Watch England will have a really good piece of work that they can share with NHS England and improvement nationally.
Brilliant, thank you, Andy. And Michelle, could I ask you, as with all the links that you see and that people pop up, could you make sure we circulate that link electronically with Andy's notes and thoughts? That would be really helpful. Thank you, Susanna. Then Kirsten.
So yeah, thank you. Agree with everything else that's been said, and just to build on Shane's comment, and what would be really good is if we could then put this, if you like, into the context of other initiatives, because also alongside this, I love the stuff you've been doing, Terry, around the Just Ask, I think it's a Just Ask video, and other initiatives as well, because I don't know if you were here earlier in the meeting, I put up a reminder of the OBA model and said, look, we're only going to shift the needle on the outcome, and we desperately want to shift the needle, don't we, on the maternal deaths and those outcomes, if we do lots of things. So this is a huge contribution and enabler for the voluntary community sector, but then if we put that alongside all the other things you're doing as well, how could we show that as kind of collectively enabling benefits to that population? And then my absolute dream is that we're sitting here a year or two from now with a really this is where people like Shane and I get really nerdy, kind of beautiful report that shows that actually we moved the needle on an outcome, and we can track back some of the data about how we did that. That would be, for me, living the dream in terms of kind of showing how we work as an ICS.
And I think, Susanna, within maternity, we often use driver diagrams so that we look at what our ultimate is and then divide it up how everything all feeds into that. And everything in our maternity programme does feed into those improving outcomes, but it would be good to put it down on paper actually and make it quite a visual thing to support that.
Well, we'll do that. We'll have another conversation, but hopefully that's what we're helping you to unpick with the way we're setting out the strategy, because we're not coming up with something new. We're just trying to organise everything we're doing in the ICS into a kind of logical, like you say, that driver thing. So we can have a look at that, and that would be wonderful. And we could get ahead on some of those measures. That would be good.
Thank you.
Excellent. Thank you both. Kirsten, lovely to hear from you, and we're very keen to hear your perspective, and welcome to the meeting. I can't now remember whether this is your first meeting or your second. I've lost track of time, but we'd love to hear from you and inputs from other partners into this, or from all partners into this agenda are so important. So over to you.
Thank you, Will. It's my second meeting, but the first one, I was brand new, so just sitting here with my mouth open in shock and awe. So thank you. I think this is an excellent project. It's always really good to involve the voluntary sector so you can really support people who need the support. And I think this is a good example that can be used to extrapolate outwards to talk about the voluntary sector in general. I often say that getting 1 year of funding is a bit of a double-edged sword, because you do have to spend the first year setting up the project. It might be something brand new that's never been done before. You have to build the relationships with statutory sector, the funders, but also with your beneficiaries, with people who are going to get the support. You might not even know where they are. They might be difficult to reach for you because you haven't, served them before. They haven't had a service, so you have to actually make those connections. And so judging on, sort of maybe normal measures that you might have in monitoring and evaluation doesn't work for the first year. The measures really have to be about, have you built those relationships, and have you found the people who need the support, who you may not have been supporting properly before. So I think that applies to quite a lot of, if not all, voluntary sector projects. And I often say 1 year's funding can set people up to fail, spectacularly, because they haven't managed to deliver what perhaps people are expecting them to.
That's one of the reasons why more, sort of a 3-year funding project is so much better. You've got your first year to set up, your second year to deliver, and your third year to think about all those brilliant things that this project has identified, the things that you could do to improve it and move it on. And the second point I wanted to make was about learning. We are going to make mistakes doing these new sort of collaborative projects with the voluntary sector. The worst thing we could do is just point at the mistakes. What we have to do is say, this is brilliant, isn't it? But there is a lot of learning that will come out of it. Some of it will be cultural. Some of it will be about resources. And I really think that what the voluntary sector could really, really do with is some help discussing monitoring quite early on, maybe even before a project starts. So you sit down and you say, what is it you want from us? And could the statutory sector actually help us to set up that monitoring before we even start? Maybe 6 months before the project is going to go live. You sit down maybe with public health or some other parts of the ICS who could really build your monitoring for you, and then you know what it is you're doing, especially if you're a small organisation and perhaps don't have the resource to do that yourself. So I think this is brilliant, and I think one of the best bits about it will be the learning that comes out of it. Thank you.
Okay. And Kirsten, do tell me if I've got this wrong. Forgive me if I have. Is your appeal there? Your appeal is general for help from all commissioners in commissioning with voluntary sector partners in the ways that you've described, both in terms of longevity of contract, and understand the point you make. And I know that the colleagues around the table understand exactly where you're coming from there, but also in your setting expectation management, please.
Absolutely, that's exactly it. And I think this example, this project, is a good one to follow, because it will show in real time how these things are being managed and what the benefits are of really supporting a project like this.
Okay. Lovely. Thank you very much. So, colleagues, any further input or questions or points? I don't see any hands raised. We were actually we were asked to comment on this paper. I think, Helen and Terry, I hope you've got some useful comments there and feedback. And I think also you should take the sentiment of strong board support for this piece of work, both for what you've done so far, but also what you're going to do. So that's great. Thank you very much.
Thanks so much.
Thank you. Thank you very much. Okay, so next item, Health and Care Professional Leadership Programme, an update, and again for comments if there are any from the board. Andrew, all yours.
I think Will is still chairing a meeting, but I can give him a quick wave.
Oh, is he not with us? I didn't check. Okay, well, while you just check that, we can always carry that one forward, Amanda, I think, if we have to, couldn't we? Let me just then go while Amanda does that. Oh, she may have some news. Go on, Amanda.
Yeah, he's coming literally. Give us 30 seconds.
Oh, is he running? Okay.
Yeah, he's just over there.
Oh, yeah.
Here he is.
Okay. Andrew, Health and Care Professional Leadership Programme, it's all yours.
I sprinted from team meeting to team meeting.
Okay.
Technology is wonderful, isn't it? I won't take up much time. I just want to top and tail the paper that I'm sure you've read, just with one or two comments. So the Health and Care Professional Leadership Programme is mandated. Can you still hear me?
Yes.
I can't hear myself, which is odd, but that's not a bad thing. Health and Care Professional Leadership Programme is mandated by NHS England, but it's also the right thing to do. And the programme in 5 bullet points, essentially, is to make sure that health and care professional leaders are able to be involved and take decisions throughout the ICS at every level from a full range of health and care professional leaders. It should include a culture of shared learning. It should support health and care professional leaders to work in the leadership space with time and also infrastructure, which is something that's often challenging. It should include an element of leadership development, and recruitment and selection into those leadership roles should be transparent and encourage diversity. The important principle at the programme in our ICS that we've been putting together is that we shouldn't put in just another governance structure. This isn't an organisation chart we're going to overlay on top of everything else that we already do. We're going to establish a network of leaders through all their existing networks, joining them together where they need to be linked up to really meet the aims of the entire programme. And crucially, that network should be led and planned by those health and care professionals. The communications and the development of that network are described in the paper. I'm happy to take any questions on them. The paper has an obvious misprint. I'd be happy if anyone wants to prove that they've read it by telling me what it is. But we're operating our sandpit event to scope out the health and care professional leadership work for the next year ahead on the 6th of January 2023. Happy to take any comments. In fact, I'd invite comments through this meeting on what we're currently planning and have in place. But a request to this meeting is that I'm really struggling to get input from social care and social workers, and any assistance any of the partners can give me to access that group of health and care professionals, which we really, really need to include, would be much appreciated. Thank you.
Thank you, Andrew. And you're not going to reveal the misprint to us then? Or
there was a heavy clue in the structure of the comment, but anyway.
What, around the 6th of January? Is that because is the date wrong?
No, it said 22.
Oh, it says 22. Yeah, I'm looking at it and I didn't notice that. Isn't it funny how your mind, I'm actually looking at it at the moment, because the reason I asked that is I'd love to attend, but I can't. I'm away on holiday on the 6th of January, so I can't do it. But even though I was looking at it, I hadn't noticed it said 22. Is your mind? This is why you need you need script readers, don't you? Really?
This is why you need neurologists, Will.
Yeah,
it's because the brain is a prediction engine. That's the explanation for that.
Yeah, absolutely. You see what you want to see, don't you?
Well, John has his hand up.
Oh, thank you for that, Susanna. Sorry, John, you aren't appearing on my screen at the moment. All yours, John.
Well, just when you finish your gossiping, Will, that's fine. Really. I myself did not indulge in the spot the mistake piece. No. But there was just Andrew said about social care PC workers. And you see, this is where I just think we have to take account of schemes that are in place already. I would be looking to nominate social care leaders in Essex through the Leading Greater Essex programme, well established and very much in the same space. And that is not to denigrate this one at all. But it's just we must not always work from the assumption that we're at ground zero to begin. And so, I have as we are a co-sponsor of the Leading Greater Essex programme, I sort of have a first loyalty there. There is the piece that we all have of how you get out into the social care providers to get to their leaders. But given the heavily fragmented nature of that market, of course, so many of their leaders are so supervisory type roles, you only have a small number of bigger players with the structures of management you're talking about. But it's just this piece of let's make sure that our geography is tied up, really.
Yeah, thanks, John. Point well made. And Andrew's nodding strongly to your comments. John, will you take that as an action, or to pass on the action to a colleague for Essex nominations?
I think the point is I'm saying that I don't know what you quite mean by that. My first loyalty is to Leading Greater Essex, you see. Okay. Peter Fairley is the best person to lob the ball to, but it's just a question of how we tie the two things together, that's all. And I'd be happy to leave Peter and Andrew to discuss that.
That'd be great. Let me go to you, Andrew, to respond, and then I'll go Nikki, Susanna. So go on, Andrew.
It's okay. John's covered it. Thanks.
Oh, has he covered it? Okay, fantastic. And Susanna, I see you popped your hand down.
I was just letting you know, people, that Andrew had his hand up.
Yeah. Luckily, Andrew is on my screen, whereas John isn't. So thank you for prompting me in the normal way. Always help me. I need it. Nikki, over to you.
Thank you. And this is the point I made earlier. And sorry, John, I put it in the chat about the Greater Essex collaboration programme. The issue is that we in Essex are working across 3 ICSs as well. And if this is mandated, as Andrew has said, then how are we joining up with the other 2 ICSs? Because my worry is that we'll have a fractured approach, and officers within Essex will be subject to sort of being involved in 3 different programmes potentially. So I'm interested to understand what conversations are currently taking place with the 2 other ICSs in terms of how we join it up. I'm happy for Andrew to send the information to myself and Peter for Essex, and we'll have a look at that. But we do, as we said, have a number of other leadership programmes, and it is about how we align them and integrate them better, I think, as well. Thank you.
Wonderful. Thank you, Nikki. And Andrew?
So just in response to that, Nikki, I completely appreciate that's a constant tension. It's the same for us as well, working over multiple. We work with multiple trusts and work with multiple footprints. We are doing things differently in SNE, and one of the benefits of doing it the way we're doing it is that we're trying to capitalise on existing networks rather than setting up new ones, which I think leads into the Lean Greater Essex comments that have been previously made, but also the fact that you have to service 3 different ICSs. So hopefully we can do that in as minimally disruptive a way as possible. But I do need access to some social workers to help scope out how they manage that interaction, how they manage that network. So it's a preparatory piece of work, but then shouldn't impact in the long term.
Okay, fantastic. Thank you, Andrew. Yes, John. Yeah.
I just want to come back because this came up in Hertfordshire and West Essex recently. We should not always assume that everything slavishly has to be done at ICS level. And sometimes it might be the right thing that a mechanism happens for Suffolk and a separate mechanism happens for Essex, as long as we ensure that the ICS is a full part of that. It can't always be the case that Essex does 3 different things. Sometimes the ICS might do something for Suffolk and we do one thing for Essex. And I just ask that understanding be in place.
Yeah. And indeed it is, John. Yes, good point, and well made and noted. And not only in the way you've described, but also that we communicate with each properly across the piece, and that we're joined up. You don't have to be identical, do you, to be joined up? And so you've got to make the most of it. And I think that's the point you're making. Let's be efficient, let's be effective, and let's be productive in the best way we can. So thank you for that. So, colleagues, any other questions or points? I don't see any. Thank you, Andrew, for the update, and thank you, colleagues, for the comments made. Andrew, I think we could summarise by saying thank you very much, and you've got wide board support, total board support for the work to date and the progress and the future plan and the direction of travel. So thank you for that entirely.
Thanks.
Okay. Sorry. Yeah. Okay. So in which case, any other business? Now, nobody's notified any other business to me, but if there is any, now is the time to raise your hand. Susanna, yeah.
So this is just a reminder to colleagues that at the moment there is the review that Patricia Hewitt is doing at the moment, and it's got a kind of series of kind of milestone deadlines in it. And we had a conversation about that at the ICS Chairs Group earlier this week, and the steer that I have from the Chairs Group is that they would very much like us, Will and I, reaching out to Patricia Hewitt to ask if it would be possible for her to spend a little bit of time for an online meeting with leaders from our system in January, so that we can have some discussion collectively as a system on her first stage report, which, as I understand it, comes out on the 16th of January. And then to kind of feed into that, the next stages of that. So Will and I, as I said, reaching out and trying to pin that down. I'm planning to make that an online meeting, so that should be quite accessible. Obviously, I'm going to be at the mercy of when Patricia is able to do that as well. But I will send out the invitation certainly to all members of the ICP, as well as the Chairs Group and some wider system leaders, if you would like to be able to be part of that. Okay.
Wonderful. Thank you, Susanna. And I'm just, in case I forget to tell you, I'm seeing Patricia on Monday, so I'll definitely raise that with her then. So, colleagues, any Other questions? Sorry, AOB points. Nothing raised. So let me go to Michelle. Michelle, any questions from the public?
No.
You're mute.
It's all right, it's playing up today because I'm streaming. Yeah, there's no questions, Will.
So no questions from the public. Marvellous, thank you very much. In which case, everybody, 12:28, 2 minutes before the deadline. Well done. Thank you very, very much for a really powerful meeting. And I know we went at pace, but some rich debates, some great debating as well. And that's part of the team game that we're playing. Have a great Christmas. If I don't see you before, try and get a break. I know that'll be difficult for some, and the pressures in all our system and all our system stakeholders are huge. So look after yourselves as well, and have a great break. See you in January. Okay. Thanks a lot. Bye.
Bye.